Good morning, good afternoon. I am Ruben Mayorga, the Unit Chief for HIV, tuberculosis, viral hepatitis, and sexually transmitted infections at the Pan American Health Organization in Washington. Welcome to everybody to this World Hepatitis Summit, as it is an opportunity to recognize the global public health problem that viral hepatitis represents, and also to celebrate an ever-increasing engagement of national authorities, civil society organizations, and other stakeholders committed to the elimination of viral hepatitis. The region of the Americas has also responded to this call. PAHO member states have expressed their commitments to respond to viral hepatitis, approving the Regional Plan of Action for the Prevention and Control of Viral Hepatitis in 2015. And together with other WHO regions and member states, they have also endorsed global health sector strategies on viral hepatitis, both at the World Health Assemblies in 2016 and more recently in 2022. Both define and call for the elimination of viral hepatitis by 2030. Aligned with the global health sector strategy, the objective of the Regional Plan of Action was to strengthen national public health responses to viral hepatitis, proposing some concrete lines of actions. First of all, promotion of an integrated comprehensive response, the strengthening of strategic information, and fostering equitable access to prevention, diagnosis, and care. The region of the Americas has witnessed a considerable progress in national and regional responses against hepatitis. An increasing number of countries have established national structures to coordinate the response to viral hepatitis. They have also defined national plans and targets and adopted national guidelines aligned with WHO's recommendations. The path towards the elimination of viral hepatitis also builds on previous achievements. All 52 countries and territories in the region have introduced the vaccine against hepatitis B for all infants during the first year of life. Moreover, the universal birth dose of the hepatitis B vaccine was adopted by 31 countries, representing 90% of the birth cohort of the Americas. This early adoption and high coverage of hepatitis B vaccination over the past 3 decades allowed the region to achieve the elimination target of mother-to-child transmission of hepatitis B, resulting in a regional prevalence of less than 0.1% among 5-year-olds. Leveraging on these achievements of the immunization programs and considering the positive experience of the elimination of mother-to-child transmission of HIV and syphilis, PAHO has expanded the elimination of mother-to-child transmission initiative, also promoting the elimination of hepatitis B and Chagas disease. Nevertheless, despite the policy uptake and the availability of new technologies, national responses to viral hepatitis continues to be heterogeneous across the region, and we have not observed a consistent scale-up of testing and treatment of hepatitis B and C, particularly in Latin America and the Caribbean. WHO estimates around 5.4 million people living with hepatitis B and 4.8 million people living with chronic hepatitis C in the region of the Americas. However, only 20% of these nearly 10 million people are aware of their status, and even a smaller number have access to life-saving treatments. Among the challenges of the region in facing to scale up services and change this scenario, we can highlight the next ones. First of all, there is a limited allocation of domestic resources to finance the national responses. Second, the high price of medicines and laboratory tests practiced in the region that are aggravated by a complex patent landscape, limiting the access to generic medications for hepatitis C. And third, the lack of robust strategic information to guide the decision-making process. There are a few key champions in the region of Latin America, for example, Argentina, Colombia, Mexico, Brazil, who have been able to implement a sustainable national response to viral hepatitis and to accelerate access to diagnosis and treatment, particularly for hepatitis C. Guided by comprehensive planning, centralized procurement, and production of investments, these countries have been able to achieve price reductions on HCV commodities, both for diagnosis and for treatment. However, the COVID-19 pandemic has proven to be a major challenge, as it has for other entities, impacting hepatitis services, and in face of such disruption, we have to renew our call for countries to restore and sustain viral hepatitis testing, prevention, vaccination, and treatment services. On the other hand, opportunities have also arisen. Never before has the seeking of decentralized, integrated novel models of care been so fast-tracked. As examples of this, we have the availability of point-of-care technologies, all oral treatments, and simplified clinical algorithms, enabling the integration of viral hepatitis interventions into other programs, including the decentralization into primary healthcare. Fortunately, we're not alone in this fight to eliminate viral hepatitis, and we can count on the support of strong partners at the national and regional levels. Some examples of this are the following. The collaboration with the Task Force for Global Health and its Coalition for Global Hepatitis Elimination has supported countries in the generation and reporting on viral hepatitis indicators. With the Drugs for Neglected Disease Initiative, we have been promoting innovative and simplified models of care to scale up access to the diagnosis and treatment of hepatitis C. We have also engaged with the Global World Hepatitis Alliance and its members in the Americas, and this has proven very successful to secure the early engagement of representatives from affected communities in the elaboration and implementation of national responses. With the Andean Health Organization, ORASCONU, Organismo Andino de Salud Convenio Politunano, and the NDEP 2030, or the Hepatitis Fund, a catalytic project to support the elimination of viral hepatitis in the Andean countries, is being implemented. The agenda of this regional session today will reflect this collaboration and the work that several countries and partners have been doing towards the elimination of viral hepatitis. During the first session, we will hear from the experiences from national programs in implementing public policies and interventions on viral hepatitis. For the second session, we will have good practices and experiences from civil society organizations and other partners. This meeting has also the objective to identify opportunities for cooperation and catalytic action to strengthen the national responses to viral hepatitis in Latin America and the Caribbean. And with this, I would like to give the floor to Patricia Vélez, who will also give her opening remarks. Adelante, Patricia, por favor. Mucho gusto.
Muchas gracias, Rubén, por la puesta al día del importante trabajo que se ha realizado en las Américas.
Thank you, Ruben, for updating us in the work in the Americas. Good morning to everybody in America, and good afternoon for those that are joining from other continents, and good night for others. For me, as a patient, survivor of hepatitis C, and as a member of the civil society of hepatitis, more important in the world, like is WHA, I am very happy to be here with all of you again in the third summit of hepatitis that we have organized jointly, WHA and WHO. And further, this is the second meeting that we have for many of the members from the Americas, and the third one for others. Well, I welcome you all to the government sector that is present today, the other organizations of civil society that are present and are our support, and to my colleagues from the civil society of hepatitis in the American continent. We are together to share what we have done, what is more things that are for the future, and to keep together. So I welcome you to this event, and I'm going to present giving a brief context of the situation of hepatitis. Ruben already mentioned the situation. And so I'm going to reiterate some of the aspects and the role that we have as civil society. So I'm going to go on with my presentation now. Can you see my presentation? Yes. Yes, Patricia, we can see it. Firstly, for those who don't know us, I want to introduce the World Hepatitis Alliance. We are 314 organizations in 100 countries. And in the Americas, we are 72 organizations. I'm having trouble moving my slides. Can you help me with it? Yes, here we are. We're 72 organizations in 12 countries of the Americas. And we are together since the World Hepatitis Alliance was created, which is an umbrella organization for all these other organizations. We work in the fight toward the viral eliminations under several international treaties. The most important are the resolutions of the WHA in 2010 and 2014, where we started requesting the member states to recognize and approach the problem of hepatitis and to carry on activities that could control and prevent this threat, and that PAHO would provide technical support and a technical assistance. In 2015, PAHO formulated the Plan of Action for the Prevention and Control of Viral Hepatitis 2016-2019, which was the first plan for the control of hepatitis around the world, drafted by any organization. And this was the base of the Global Health Sector Strategy of 2016. This strategy set the targets to eliminate hepatitis B and C as a public health problem by 2030. And based on this, we have worked in the last years together and with the more specific guidelines. The next strategy that I'm going to talk about in this session, and which has been also approached in this summit, and it's a new strategy, and I'm going to talk about it further on. Dr. Mayorga already updated us on the situation of the hepatitis. I'm just going to remind some of the data. When we started this world strategy in 2015, we had 7 million persons with hepatitis B and 7 million persons with hepatitis C in the Americas. Now in 2019, we have under 6 million persons with hepatitis B and under 5 million persons with hepatitis C, but we still have only 3% of persons that are diagnosed with hepatitis B that have received treatment, and only 18% of persons diagnosed with hepatitis C that receive treatment. And the percentage of diagnosis is still low, 22 for hepatitis C and 18%. Even if we have higher numbers than other parts of the world, we're still the serious challenges. And we still face more death by hepatitis C than by hepatitis B. And there are regions in the Americas that have been hit harder by hepatitis B and than hepatitis C, like the Andean region. Based on this situation, what is it that we do as civil society, and also jointly with other partners that are engaged in fighting this problem? Because it's not only the civil society, it's also the governments, other institutions and organizations that support us, the WHO and PAHO. This is a photo of the summit in Brazil in 2017. We we celebrate the Hepatitis World Day before the WHO established it officially. But since it's been official in 2011, it was the first day that we celebrated together. And we had the slogan that hepatitis affects us all and that we needed to know it and face it. And then with PAHO and WHO, we had the same slogan. But in 2017, we launched that No Hep program, and our slogan was let's eliminate hepatitis. In 2018, we had our program to find the millions that still did not know their diagnosis. So those 3 years, 2018 to 2020, we used the same slogan, and we in WHO and PAHO used other slogans, but we also support them. These are photos from 2020 when we talked about a future without hepatitis, and we continue in 2021 together jointly. We have the same slogan, HEP can't wait. And in 2021, we changed the logo of the World Day of Hepatitis with a more modern, more simplified logo. We have also organized jointly with the WHO, the World Hepatitis Summits. The first one was in Scotland in 2015, where we all agreed on eliminating hepatitis. In 2017, we gathered in Sao Paulo, and we subscribed 2 declarations. One on behalf of the governments, and another one from the civil society. But we all committed to fight to eliminate hepatitis, and that is where we are. And we are also going to have the declaration of this current summit. We have had advocacy in the government with legislators, with ministries of health, so that the person with hepatitis are cared for, are treated as a human right based on universal care. We have also used media, radio, the press, internet, and TikTok, as many organizations have done in the Alliance. We have also approached the consequences of hepatitis, like liver cancer, because we have to recognize that hepatitis B and C are a very important cause of a hepatocellular carcinoma in our region and around the world. We also participated in education and training. We educate persons with hepatitis and the community. We educate health professionals. We educate not only in hepatitis, but in the transmission ways, but also we train in HIV and hepatitis. And we do it in several ways, in formal settings, informal settings, even with webinars like this one, that we, our Hepatitis C Mentor and Support Group of New York, which will take place on June 16 of this year. We invite you all because we're going to talk about how to reach the neglected population groups. We have also screened in the World Hepatitis Days and around the year to try to find the missing ones. And as Dr. Mayorga says, there's still a high percentage of the infected population that is not aware of their diagnosis. We also work in prevention with vaccination campaigns, both in the Hepatitis World Day as in other moments. And we also support our patients, not only procuring medication and care, but doing this in a humane way, in a way that only us that suffer from the disease can understand. These are photos from different countries. To the right, we have our ex-president, Michael Newgard, and his association providing support to a homeless person. We have also contributed with PAHO and WHO in diverse activities. Here are in the consultation that took place for the new global strategy. We also cooperated with the ministries of health and PAHO, and we are also participating in the NDM project for the elimination of the hepatitis in a meeting in Guatemala, my country, that jointly with the HIV program and tuberculosis of the Latin American region, we came together with a civil society suffering from these diseases. And what do we have for the future? The new strategy. I'm going to touch upon this briefly because we are going to have a Patricia, we need to wrap up because we are falling late. Here, I just want to mention, I'm going to wrap up now, that this new strategy is a joint strategy. It has been presented in this summit, but is a joint strategy of the diseases HIV, viral hepatitis, and sexually transmitted infections. And what I want to point out or highlight is that we have a place, specific place for civil society, because we are the ones that could monitor, follow up the actions centered on persons, and provide quality care, which is what people ask for. This strategy, there were consultations from PAHO to all the different sectors. So it is validated in the region. And we have worked and we have changed as civil society the landscape of hepatitis, but we are still facing challenges. Dr. Ruben also talked about it. We need more funding. We need expand access to diagnosis and treatment. And we need that the human resources can implement the new tasks in decentralized hepatitis. So we still have a lot to do. And let's keep in mind that regardless of the crisis of COVID or monkeypox or anything else, every 30 seconds, a person dies from diseases related to hepatitis. So the hepatitis can wait so that we can continue to work and fight together. Thank you. This is a beautiful photo of 8 volcanoes of my country. And in that peace and this calm, I wish that we will be when we eliminate this threat. It's
and these beautiful volcanoes at the end. Please, I would pass the floor to Dr. Ward and Dr. Sereno for the first session. The floor is yours.
Thank you, Dr. Ruben. My name is Leandro Sereno. I'm the Regional Advisor for Viral Hepatitis at the Pan America Health Organization, Regional Office for WHO for the Americas, based here in Washington. I'm going to switch to Spanish for a little bit. Bueno, muchas gracias, bienvenidos a todos a esta reunión.
Thank you very much. Welcome all to this session to talk about the response to the hepatitis across the American continent. And Dr. Ruben, the objectives of this meeting is to share experiences of activities and policies that are implemented by the programs in the region. So we're going to listen to some of these experiences in some countries and some activities in some regions in South America. And I also want to use this opportunity to thank the availability of the speakers that are here, which are from ministerial programs that have busy agendas and are facing COVID problems. We have other 2 crises, which is the acute hepatitis in children and also the monkeypox. So thank you for your availability and your effort for being here. I'm going to give the floor to Dr. John Ward, who is a moderator of this session, so he can introduce himself and inviting the first speaker.
Thank you, Leandro. It's great to be joining you as a moderator of this session. I think Ruben and Patricia set the stage very well, giving a lot of context to the state of affairs in the Americas and the critical role of civil society and persons affected by hepatitis B and hepatitis C. Also appreciate Ruben recognizing the the agreement the PAHO has with the Task Force for Global Health and the Coalition for Global Hepatitis Elimination to work together to promote, share lessons learned and promote effective strategies throughout the region. This first section of this program today will really focus on different aspects of implementing effective programs, ranging from a micro elimination approach to a national approach to a multinational approach. So let's get started straight away. It's my pleasure to introduce Carlos Benitez. He's the coordinator of the National Program for Viral Hepatitis, HIV, and STI Prevention in the Ministry of Health of Peru, and he'll be talking about the micro-elimination of hepatitis B in Peru. Carlos?
Muchísimas gracias, doctor Ward, doctor Sereno.
Thank you very much, Dr. Ward, Dr. Sereno. I thank the WHA for the invitation to this event, and I want to greet all the participants. I'm talking on behalf of the Ministry of Health of Peru. I'm going to present the national experience on the microelimination of hepatitis B. And as it has been commented previously, as hepatitis C, it affects our region, and particularly both the Andean and the Amazon regions. It's just to let you know, my country is we are close to the Pacific Ocean. Some demographic data, we have more than 33 million inhabitants. The third part of our population resides in the capital, Lima. We are a high income country, but still with poverty. We have 25 political regions. Each of them has a budget and program autonomy. 8 natural regions, and this is very important, 55 native populations, 51 reside in the Amazons, and 4 in the Andean region. It is important to mention how we started, and this started when they started to be approached when we had a dramatic situation in 2009 in the Amazons, where the heads of the people in the Amazon started to report the problem of hepatitis B cases, complicated cases, and deaths. Specifically in an indigenous town in this part of my country, which is the Datem del Marañón in Loreto, which is an Amazonic region. And based on this, there was a national mobilization with active participation of civil society, but it was a very rapid response from the state, declaring an emergency, health emergency situation, and they took immediate action to improve prevention and guaranteeing or ensuring or safeguarding these populations. This is the Ministry of Health, and one of the leaders, Venancio Ucama, from these populations. And since 2010, the decision, the beginning of the prevention and control of hepatitis, together with HIV and STIs. The next year, we published the first guideline for treatment and diagnosis of hepatitis B in Peru, and on June 20, and we're going to celebrate it in my country soon. And this was declared as the National Day of the Fight Against Hepatitis B. And this is in addition to June 28, which is the World Hepatitis Day. I want to highlight the importance of the program to have strategic information. Despite that this problem became visible in 2009, as I mentioned, the cases in the Amazon region been reporting since 1996. In this study, which was one of the first ones, they reported a prevalence of hepatitis B of 9.4% in 12 basins of the Peruvian Amazon. In 2015, we were able to complete the first national surveys of 5 viral hepatitis, but for hepatitis B, we documented a prevalence of 0.4%. And we found 4 regions with a prevalence between 1 and 2%, and only one above 2%, which is in Cusco. And more recently, in 2019, we evaluated a series of diseases, including hepatitis B. In this initial reporting cases, and we found that Candochi has a prevalence of 1.69 of hepatitis B, but we found other population, the Achuar, that reported 3.31%. So the problem continues. What are the key program interventions that the hepatitis program has been implemented in prevention, information and counseling, the use of condoms? As program, we have specific immunoglobulin against hepatitis B, which we use in the newborns exposed to hepatitis B, and routine vaccination for under 1, in the 1 to 5, and in the general population. I want to highlight the importance of rapid tests for hepatitis B, which has allowed us to reach the most remote corners of our country, to work outside the health facilities with with community health workers, with basic training. And I want to mention that recently we have incorporated the molecular diagnosis with the Gene Expert platform that functions for HIV, hepatitis B, and hepatitis C. And I also want to mention that in terms of treatment, we have tenofovir and entecavir. And this is very important as a program, but in addition, I want to highlight this, the program has funding that is part of the a budget based on results. There is a specific budget for hepatitis B since 2018 and for hepatitis C. And this is the specific budget, it's a specific allocation for actions of prevention and control. I'm not saying that this is enough. We are still facing gaps that we have to close. And because of this, and based on the information we had, we decided to focalize interventions. I also mentioned the very concrete experiences in the region of Loreto and Datem del Marañón, where I want to highlight the participation of local authorities here with the mayor, the importance of vaccination as the main prevention measure, social mobilization mainly from the young persons, the work of tracking contacts at household level, which is something we have to expand, the complexity of working in the Amazon region, and truly that the population has mobilized. It's been instrumental for this focalized interventions. And in this other region, in the Andeans, in Ayacucho, the province of Huanta, likewise, the commitment of local authorities is very important. The training of health, even with specialists, gastroenterologists, infectologists that participated, and the social mobilization and working materials and communication strategies that are culturally appropriate. To focalize interventions has allowed us in a good way to mitigate the impact both in mitigate hepatitis B, both in access to tests as in terms of continuing increasing our treatment coverage for hepatitis B. In 2021, more than 1,400 patients that receive an antivirus with direct action. 45% of the hepatitis B in treatment are from the 2 regions of the focalized interventions, Ayacucho and Cusco. I'm going to wrap up talking about the challenges which are of utmost importance in our region. And among these challenges or these gaps or barriers, we have two key elements: cultural barriers. And for this, the participation of the community and the intercultural dialogue as a tool is fundamental to meet with the population, with their leaders, create dialogue spaces is key to advance and to adapt the communication strategies to the cosmovision and using the language and the practices of the people that we target. And the other fundamental barrier is the geographical barrier. And for this purpose, the health services are not enough. Our offer is not enough, is limited, and it's totally necessary to implement a mobile option through the implementation of brigades. Many times or frequently, because of the geography of the Amazons, they have to move through by rivers, by boat, and the strategies of including in the teams the indigenous health promoters, the famous peer strategy that we learned in the HIV programs is being incorporated in the strategies, and also tracing contacts at the household levels has allowed us to find more cases and to link them to treatment. And to wrap up, the perspectives in the country, we are in the midst of a process to finish our national plan for the elimination of viral hepatitis. We have already incorporated the approach to hepatitis C, and this would help us to understand the financial gap to be able to reach these ambitious goals. We know that we have a wide gap. We know that the gaps for working in the Amazon in terms of financing are higher, and the plan is seeking to improve this situation. And also the model to work in this community, it can always be improved. We have to continue improving it. And we also have the challenge to expand to other regions where there are documented prevalence above the national mean, where we might need to find better data on the prevalence of hepatitis. We also consider it is very important to work with our neighbors, both in the Andean region as with the Amazon, to evaluate bilateral interventions or multilateral interventions in the borders. And the challenge, of course, as has already been mentioned, is the financial sustainability of these interventions and interventions in the Amazon. Just the fuel, the gasoline represents 50% of the cost of the interventions. And this consideration is very important to understand, and that it can be included in the budget for our work in this complex settings in our country. And this is our team at the Ministry of Health and the HIV team. We are in the National Stadium of Lima. We have an important commitment to be able to get to the Soccer World Cup. Thank you for your time and for your presence.
Thank you, Carlos. Great description of that program. A lot of questions come to mind for me as far as how did testing remain constant and even increase during the pandemic response, and was interested about your catch-up vaccination strategies for this population. But so be thinking about that, please. And let's see if we can cycle back to that during the discussion, as we are a few minutes behind schedule, and we want to be respectful of the other speakers that have been asked to present. And in that regard, it's my pleasure to introduce the Honorable Dr. Frank Anthony, who's the Minister of Health for Guyana, and will be speaking on building the national viral hepatitis response and opportunities for integration. Dr. Anthony, please.
Thank you very much, Dr. Ward, Dr. Sereno, other persons who are participating. First of all, let me thank Sorry, I think we are having some technical difficulties. I hope you can hear me now.
Loud and clear, please proceed.
Okay, thanks. Dr. Ward and Dr. Sereno, thank you, and PAHO WHO and, for inviting us to participate in this year's World Hepatitis Summit. Guyana is pleased to talk about its program and to share some of our limited experience that we've had so far. Next slide, please. So basically, our program consists of our vaccination program that we do for hepatitis B. We have a safe injections program to make sure that we can keep people safe. And of course, we want to do diagnostics and make sure that we are treating people and surveillance. In terms of our hepatitis B vaccination, we have been able to provide good coverage for childhood vaccination. And we're also working to make sure that at birth, children are able to get their vaccination. We have also been working to make sure that hepatitis B vaccines are available for our healthcare workers, although some of them are reluctant to take the vaccines, despite it being available. And we are also working to make sure that persons who are at risk would be able to access these vaccines. In terms of safe injection, the syringes and everything that we used are disposable, so we are not reusing anything, and therefore this program has really helped to prevent infections. Diagnosis, we have been able to offer diagnosis to persons who come into our HIV STI programs, and we also have 100% coverage with our blood donors. And we are looking at other high-risk groups where we can do diagnosis and then offer treatment to those persons who are diagnosed with hepatitis B. Our surveillance, we need to do a lot more work there because we don't have integration of data. And that's something that we definitely would have to work on. Next. This is just to give you a glimpse of some of the cases that we have been able to discover of Hep B using blood donors. And as you can see, we are able, through that 100% screening that we do at our National Transfusion Service, to be able to detect a number of persons who are hepatitis B positive. And once we detect those persons, we are able to place them on treatment. A number of our HIV STI patients, and because we are now offering PrEP, we are able to detect persons early, and once we detect people, place them on treatment. Next, please. In terms of Hep C, similarly, we have been screening our blood, and through that process, we have been able to detect a number of persons who would require treatment. Unfortunately, we have not been able to offer treatment to these patients. And so we have been working directly with PAHO, and from this year, we are hopeful that we can start offering treatment for patients with Hep C. The other categories of patients that we screen are HIV and STI patients, and we have been screening our dialysis patients to see whether or not they have Hep C. And if they have, we are going to put them on the treatment program. Next. So in terms of Hep B, we have our prevention component, And here we want to work to increase the birth dose, the coverage for birth dose. We think we're doing fairly well in terms of the vaccination of children. And we also want to look at those who are at risk to be able to vaccinate them as well. Diagnosis, we think that we can expand it, especially in some of the other regions of our country, the hinterland regions, and that is something that we are working on. We have, in some ways, benefited from COVID because we have now been able to put a lot of the laboratory diagnosis or equipment in many of these regions. So we have GeneXpert machines that are available in all the regions. So what we'll need to do is to use the cartridges to make sure that we can do timely diagnosis of Hep B. In terms of treatment, we do have Truvada that is available. And at all our district and regional hospitals, we are able to offer this treatment. We are also now working to make sure that we can offer the treatment at some of our specialized health centers. And we have been training doctors to make sure that they can deliver this type of care. I think one of our big challenges is collection of data and synthesizing that data, making the analysis, and then making sure that persons who we have diagnosed, that we are able to put them on treatment. This is an area that we recognize, and we'll be working to make sure that in the coming years that we improve on this aspect of our program. Next. In terms of Hep C, while we have been identifying patients for a number of years, especially for blood donors, we have not really been able to offer treatment. That is going to change this year because we have been working directly with PAHO WHO through the strategic fund. And we are hopeful that we'll be able in the next 2 months or so to access medication for these patients. We have identified approximately 500 persons who would require treatment. And with the protocol that we are using, our understanding is that it's about more than 95% effective. So once we start that treatment program, obviously we'll monitor to see whether there are any treatment failures. But we feel by doing this, we'll prevent hepatic failure and ultimately hepatic carcinoma. So this is something that we are working on. While we are awaiting the arrival of the meds, we have been training our staff. We have developed guidelines and protocols. So we have been putting that in place. We have identified some specialized clinics where we are going to do this. And we're just waiting on the meds now to start that program. Next. Next. So we in Guyana, we have embraced the WHO targets for 2030. We are very optimistic with the programs that we have in place and what we'll be doing over the next couple of years, that we will be able to decrease the incidence of both hepatitis C and hepatitis B, and also by the treatment programs that we're introducing, that obviously we'll be able to decrease mortality. We have some targets set for up to 2025, and then we'll do a review to make sure that we are on track to eliminate by 2030. So in a nutshell, this is what our program looks like, and we will welcome sharing of experience with other countries and learning from other people what they have been doing. But our Hep C program or treatment program really starts this year. So in the next 2 months, and perhaps the next time we meet, we'll have data to report on how the Hep C program is going. Thank you so much.
Thank you so much for that very concise and very informative presentation, Dr. Anthony, and we look forward to working with you as you launch your Hep C program. I do want to mention that there's more information about the Peru program on the Coalition website at globalhep.org as they developed a national hepatitis elimination profile, so people can go there for more information. For both Dr. Anthony and Carlos Benitez, please place questions in the chat. For Dr. Anthony, it would be interesting to learn more about what they have in plans to for their launch of hepatitis testing and linkage to care and treatment. So again, please be thinking about that, and we'll do our best to cycle back to that in the discussion. As again, we're a few minutes behind the time, unfortunately, to pose those questions to you at the moment. So let me move on to Paolo Baladelli, who's the Sub-Regional Program Director for South America with PAHO, and he will be talking about opportunities for sub-regional cooperation, viral hepatitis elimination in the Andean region. Paolo?
Thank you very much, Dr. Ward, and for your introduction. And I would like to take the opportunity at the beginning of my intervention to bring the warm regards from the director of PAHO WHO of the American region, Dr. Carisse Etienne, and also from my team of the sub-regional program of PAHO WHO for South America. We go directly to the first, to the following slide, where we take into account what Patricia Velez at the beginning said. Please, the next. Here you have the regional plan of action for prevention and control of viral hepatitis for 2016-2019. 5 strategic lines of action are considered. The first is integrated comprehensive response, then equitable access to preventive care, equitable access to clinical care, and strategic information and laboratory capacity. I start from these 5 blocks because our project in the sub-region of the Andean sub-region started exactly looking at how to implement the regional plan of action. In the following slide, you will see which are the countries which are comprises into this specific project. As you see, it is a multi-country project. You have Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. And the estimation of people living with hepatitis B is 2 million. Same for hepatitis C as a 2 million. And this burden of disease affects mostly the most vulnerable population. As before also the authority from Peru mentioned, lot of prevalence was found in indigenous population, especially of the Amazonic region. In the following slide, we'll see what the country, the Andean country, have worked in the response. And you see that the first line is planning, working on national plans, program, and strategy. The access to preventive intervention, testing, and treatment through elaboration of clinical guidelines for the diagnosis and treatment of viral hepatitis and the provision of vaccine. Also, the revision of drugs lists for the treatment of virus hepatitis and updating the laboratory capacity. A third line is the strategic information, such as the implementation of surveillance strategies. So collecting data on virus hepatitis and investment studies for hepatitis B and C, meaning investment studies looking at what is the cost of the investment vis-a-vis the results that we can achieve through that type of intervention. In the following slide, we see what was the situation at the end of 2019 in a snapshot. So 4 out of 6 Andean countries had developed a national hepatitis program strategy and clinical guidelines aligned with WHO. 3 out of 6 countries have committed to the goals of elimination of viral hepatitis. 5 out of 6 have introduced the universal best doses of the hepatitis B vaccine to newborns, and 6 out of 6, so the totality, have developed the laboratory capacity for screening, diagnosis, confirming, and follow-up of viral hepatitis patients. The following slide, you will see that what are the key enablers of the sub-regional cooperation. But here I want to mention that the Andean Committee for HIV/AIDS and Hepatitis had really a very crucial role. You know, the 6 countries have expressed delegates from their ministries of health, so that an Andean committee is up and running. And on 2019, in Santiago de Chile, these representatives from the 6 countries met and together with the Organismo Andino de Salud, which is the specific Andean organization with member states from this sub-region, and the Pan American Health Organization. The objective of the meeting was to identify strategies to eliminate viral hepatitis as a public health problem in the Andean region. And a declaration was issued with a series of recommendations. And then it was ratified, this declaration, in the meetings of ministers of health from the Andean countries on April 16, 2020. So you will see a lot of the work from this specific program or project, which is a multi-country, is to pull together the political willingness from the ministries of health and together work on horizontal cooperation in a way that results can be achieved for the population of these 6 countries. In the following slide, we go into seeing what is the specific declaration of Santiago of July 2019. You see that there are 5 important blocks: the price negotiation for the access to generic drug, the best doses of vaccination in the 24 first hours, the strategic information system, the screening strategy tailored to population group, and the adherence to recommended guidelines for prevention and treatment of hepatitis. It's really very important to stress that the ecosystem of this sub-region, with a strong component of indigenous community and migrant population, is key to be addressed because this type of population are mostly neglected and they are very dispersed in the area. So it's very important that the project works with this population, very vulnerable, and producing also an active participation of the civil society and with good communication strategy and messaging. Before it was said by our authority from Peru that we have around 60 indigenous groups in Peru. And this multiplied by the 6 countries, you can have even more than 100 different groups with different languages. This poses really a challenge. And what this project also has addressed is how to come to a language and ethnic characterization that makes messages and makes awareness more understood by the indigenous population. We have 2 types of indigenous population, one for the Amazonic region and one for the mountain, from the Andean regions. The following slide. So this project has really supported national responses, but doing it in a way that countries work together. The partners of the project, as you can see, is the Hepatitis Fund, which is also an important component for the financing of the project itself. Then the Andean Committee of HIV, STI, and Viral Hepatitis, which is formed by the different ministries of health of the 6 countries, the Andean Health Organization, ORAS-CONO, PAHO, WHO, our sub-regional program for South America, and experts on hepatitis response, such as Nick Walsh, really a very important asset for the project itself. In the following slide, you will see the challenges, the main challenges, and how we have grouped them into 3 main action points. So for reason of time, I do not go through the challenges. You have them on the slide, but I want to mention especially what are the 3 main blocks of the project. The first is advocacy and awareness. The second one is national hepatitis policy and planning, including all the protocols for the attention in prevention and care of hepatitis. And finally, the testing treatment. The following. So these are the key challenges, as you can see, for the Andean region. Again, it's important to stress that working together, the 6 countries have more likelihood of addressing effectively this challenge. The first one is the political commitment. The second, access and cost, the chronic lack of funding, the strengthening of the civil society for a good engagement, and finally, the awareness and the national testing strategy. The following. And here you have an example of communication messages. This is the last slide, and you can see that we try really to include the different groups also into the images which are circulated with the messages, so that people can see themselves within and recognize, identify themselves in it. Thank you very much.
Thank you, Paolo. Again, you raised some very interesting perspectives regarding the benefits of countries that are in the same region coming together for planning and program implementation. Some areas that would be interesting to explore, in my view, are some of the benefits of that. You touched on them a bit with multicultural aspects of populations that are shared across these countries come to mind. Interested in any reductions in cost because of bulk purchasing of commodities. And I think we'll hear tomorrow what's called catalytic investments, of how international investments can spur national investments. And it'll be interesting if that's beginning to come about with this project. But again, in the interest of time, since we're a few minutes behind, hopefully we'll be able to get to that in our discussion period. I'll turn it over to Leandro to introduce our remaining speakers. Leandro.
Thank you, John, and thank you again for all the speakers for the great presentations. Siguiendo entonces con nuestra sesión.
So going on with our session, I want to invite Alexis de la Torre Rosas. Dr. Alexis is an infectologist, a physician. She has a master's in public health, and currently she's the general director of the National Center for the Prevention and Control of HIV, SENCIDA, in the Secretariat of Health of Mexico, and she will present the experience of the elimination of hepatitis C in Mexico and financial opportunities in the country. Dr. Alexis, go on.
Thank you, Leandro. Putting an end to hepatitis as a public health problem And in doing so, we have promised to fight for the human right of health, to not leave anyone behind, and to end inequalities that so often follow this disease. In Mexico, liver disease is one of the leading causes of mortality, with hepatitis C accounting for 60% of liver transplants. As with other countries, there is variation in the incidence across the regions. In Mexico, PDA treatment for hepatitis C was licensed for clinical use in 2017 by the National Regulatory Agency. Despite treatment being paid by the government, it was very difficult for people to access this treatment due to several selection criteria that limited those patients deemed eligible. In addition, only few public care centers and specialists were authorized to provide DAA treatment. By the end of 2019, Mexican government had designed a program with the objective of having a coordinated response across all public health care institutions and to expand the coverage of services for prevention, detection, and treatment of people living with hepatitis C. We changed our aim from that of treating only a few patients in some institutions into one of embracing all the goals of elimination. We aim to design a person-centered program able to reach people who have historically been affected by stigma and discrimination, gender-based violence, social inequality, inequitable access to health services, as well as those who the law criminalizes and whose rights not yet fully recognized. Only by including all these voices, we will be able to understand the health outcomes that are important across their life cycle and be able to provide the prevention measures and the health care that is needed. Thus, Mexico's national program was developed through consensus with the main national stakeholders, including public health institutions, financial authorities, the pathology and infectious diseases specialists, and of course, social civil society. The program is based on 4 main pillars: a national procurement strategy to ensure universal free of cost access to hepatitis C screening, diagnosis, and treatment, standardized online registry to measure real-time the health outcomes that are important to people, as well as to promote benchmarking, direct improvement strategies and research, a primary healthcare approach, unifying actions independently of the public healthcare providers, regions, and states.
Doctora Alexis, perdón, pero creo que estamos con un problema con el sonido, el audio no se escucha bien. Si puedes mover su micrófono más
We
cercano.
have serious problems with her audio. It is we're having problems with the interpretation. Yes, that's better.
Elastography is not available in primary care clinics, and patients are stratified on non-invasive methods, which allows primary care physicians to identify those patients where additional studies or guidance is needed. Social communication and telementoring network strategy. Most patients are treated now by primary healthcare physicians, and a network of gastroenterologists, infectious diseases, mental health specialists was created to help guide complex cases and facilitate referrals when necessary, and strategies focused on high-risk groups as well. So no country has unlimited resources to achieve the international goals and sustain them if we don't make sure that adequate human resources, medical, purchasing, distribution, and adequate usage mechanisms are in place. So in order to achieve our goals, we use a 3-step plan for the financial optimization of the program. Different actors, including clinical and community leaders, as well as public health and financial sectors, participated to achieve the goal of having treatments aligned with the international guidelines, providing value for both people and our healthcare systems. So it was first a clinical optimization, which allowed us to have the identification of the best therapeutic options then the public health to verify that all populations were included, and the identification of potential equivalents and gaps, and then the financial optimization through a consolidation of the national demand and competition between equivalents. And that allows us to have a very good deal for the program. But scientific progress and supplying institutions are of little use if people cannot access their medication or care. Thus, we also need to be aware that healthcare systems and programs need continuous improvement and innovation, and that we cannot end a public health problem if we do not focus on reducing geographical, economic, cultural, and structural barriers. We needed to invest in human resources in every single region to promote and catalyze the program. We optimize our healthcare force to avoid duplication of activities and avoid losing detection and integral care. The results were clear, as you can see on the map. In 2019, there were less than 20 units across the country for people without insurance to be evaluated and potentially receive treatment. And the program started in 2020. And despite the COVID pandemic, by the end of that year, more than 150 primary healthcare centers were able to evaluate, diagnose, and provide treatment. The model has continued to grow, reaching remote areas. For instance, in one state, we have more than 340 remote centers to reduce barriers to people. And of course, we took the lessons learned from the HIV pandemic and recognized that community leaders, peers, advocates are at the center of the strategy. In addition, avoiding working in silos is also a crucial component. We created an observatory and we have meetings every 2 weeks to keep pace of the strategy and promote benchmarking, innovation, and research as we learn from each other. And in order to have a professional workforce, we have developed online courses as well as telementoring strategies to make sure primary healthcare workers have guidance of specialists across the country. And one of the main pillars of the program has been the creation of a person-centered registry. We are able to trace real-time the screening, diagnosis confirmation, treatments, risk factors, amongst other variables. We have now over 30,000 people with rapid test positive that has been identified and now are in confirmation of their diagnosis or treatment. And checking progress is also essential. We thank the Coalition for the Global Hepatitis Elimination. Using a standardized profile has helped us to identify needs not currently covered, for instance, developing guidance not only for hepatitis C, but also for hepatitis B. Therefore, we work together to have a new update, which is currently in an open review period. And here you can see the main groups that have been reached by the strategy over the past 2 years. An evidence-based plan is essential, and we thank PACO and the CDA Foundation for the technical support, in particular by helping us to better understanding the dynamic of the epidemic in Mexico, as well as promoting learning from each other. We cannot achieve elimination goals alone. No government can act without the insight and help of communities and civil society, without academics and researchers, without healthcare workers. And of course, by extension, no country, no region should be left isolated. Sooner or later, inequalities will affect everyone. Together we're stronger, and progress and sustainability changes will only be feasible if we also work alongside aiming to a human rights person-centered resilient system capable of responding to multiple hazards without stopping the hepatitis elimination agenda and services. Thank you.
Thank you so much, Dr. De La Torre. Bueno, es muy interesante el trabajo que estamos.
It is very interesting, the work in Mexico, your planning and implementation, and also the experiences in integration with hepatitis, with other services, with HIV, and with primary care. And this has been commented in the summit, the new recommendations of PAHO in regarding to this topic. And this is an experience that it is important to share so it can inspire other programs. Thank you.
So, following up on the program here, on the session, I'm pleased to invite our next speaker. That's Jessica Deering. Dr. Deering, she's an epidemiologist with national and international experience responding to communicable disease outbreaks. And she is currently serving as the viral hepatitis policy advisor at the Office of Infectious Disease and HIV/AIDS Policy in the U.S. Department of Health and Human Services in the United States. So, Dr. Deering, you have the floor, please.
Thank you so much, Leandro, and thank you to the World Hepatitis Alliance and PAHO for inviting me to join you for this summit. So today I'm going to talk to you about development of the Viral Hepatitis National Strategic Plan and the Viral Hepatitis Federal Implementation Plan, and how the plans address syndemic approaches and health equity in the United States. The Viral Hepatitis Plan was released in January 2021, and it is the first elimination plan for the United States. It is intended to serve as a roadmap for stakeholders to guide development of policies and initiatives at all levels. It focuses on hepatitis A, hepatitis B, and hepatitis C, the three most common viruses in the U.S., hepatitis viruses in the U.S., and the plan is necessary as the U.S. is facing ongoing hepatitis A outbreaks. Progress on preventing hepatitis B has stalled, and hepatitis C incidence rates tripled from 2011 to 2019. The vision and goals are listed here. There are 5 high-level goals in the plan. They focus on prevention, improving health outcomes, reducing disparities and health inequities, improving surveillance and data usage, and achieving integrated, coordinated efforts. The 4th goal, focusing on surveillance, was a new addition to this plan to bring more attention to this need. Here is an overview of the plan. Its aim is to eliminate viral hepatitis as a public health threat by 2030. It is a 5-year plan, but it has indicator targets that go out to 2030, aligning with the WHO targets. My office coordinated the development of this plan, but we worked with a large group of federal partners called the Federal Steering Committee, consisting of 6 federal departments and 13 health and human services agencies and offices. We also provided multiple opportunities for external stakeholders and the public to provide input. The plan recognizes the importance of addressing stigma, discrimination, and social determinants of health. The plan takes a syndemic and whole of society approach. It recognizes the intersections and synergies across the epidemics of viral hepatitis, HIV, and STIs, and the opioid substance use epidemic. And this is how we define the syndemic. Thus, it calls for an integrated approach to prevention, screening, and care and treatment among all components of this endemic. Our approach to integrating services for viral hepatitis, HIV, and STIs aligns with the global health sector strategies. The viral hepatitis plan was developed concurrently with the HIV and STI national strategic plans for the United States, and there are many areas of alignment, which I will discuss later. We allowed multiple opportunities for external stakeholders to provide input during development of the plan, as well as on the draft plan. We held 18 listening sessions and posted a request for information in the Federal Register before development of the plan and after a draft was available. All comments were analyzed and taken into consideration while we finalized the plan. And these comments were also disseminated to all of our federal partners who were involved in development of the plan. The viral hepatitis plan is one of 4 national strategic plans that were released by my office in 2021 and 2022. We took a syndemic approach to the viral hepatitis, HIV, and STI plans, and they are all aligned in our goal to integrate and coordinate efforts that address each of these disease areas, as well as substance use disorders with stigma, discrimination, mental health, and social determinants of health. And I will share some examples of this approach in the following slides. The plan is organized with the high-level goals, those 5 goals. Next is the objective, and then following that are the strategies. Here is an example of an aligned objective and some of the language within each of these plans that promote integration of programs to address this endemic of viral hepatitis, HIV, STIs, and substance use disorders. This slide goes into more granularity of similar strategies across the plans. So for viral hepatitis, we discussed providing vaccination at a broad range of clinical and non-traditional community-based settings, including HIV, STI, and STI clinics and organizations that serve people who use drugs. Similarly, in the STI plan, we include integration of STI prevention with HIV, viral hepatitis, and substance use prevention services. And in the HIV strategy, there's a strategy focusing on integration of HIV services into outreach and services that intersect with HIV, such as STIs, viral hepatitis, and substance use and mental health disorders. And then there are similar strategies that discuss integration of viral hepatitis testing into a broad range of settings. And you'll see similar strategies for STI and HIV screening in those plans as well. There's one more slide that shows alignment across the 3 plans and the strategies. We emphasize developing whole person systems of care that address co-occurring conditions for people with and at risk for viral hepatitis, HIV, STIs, and substance use disorders. And then similarly, the STI and HIV plan include strategies to expand patient-centered care models and implement a no wrong door approach across this endemic. We also include strategies to work to align indicators, integrate surveillance data, and align strategic planning across this endemic. And we know these are lofty strategies, which will take a lot of work to achieve. Shifting gears a little bit here, I wanted to share how the U.S. Viral Hepatitis National Strategic Plan also addresses viral hepatitis disparities and health inequities. The bullets listed here are the high-level objectives from Goal 3 of the plan, and at the bottom is a table of the priority populations for disproportionately impacted populations that we called out in the plan to focus efforts. But I do want to note that the U.S. now has universal adult hepatitis C screening and universal hepatitis B vaccination recommendations. So these universal recommendations will can reduce stigma associated with risk-based screening and risk-based vaccination recommendations, and reduce the need for providers to assess stigmatizing risk factors, and increases opportunities for screening and vaccination for all. One example that our office worked to help reduce discrimination was a release of a letter raising awareness that there are federal laws prohibiting discrimination on the basis of disability, including people with hepatitis B. There are unfortunately still discriminatory practices occurring against people with hepatitis B within health education programs. So we encourage health professional schools to review their policies in this letter. So next, our office helped coordinate the Viral Hepatitis Federal Implementation Plan, which was just released in May of this year. And it outlines activities federal agencies commit to in order to achieve the goals outlined in the strategic plan. The implementation, implementation plan was developed with the same federal departments and HHS agencies that developed the strategic plan. And we also provided opportunity from external partners to provide comments on the draft implementation plan. The implementation plan is a way to ensure accountability and to facilitate collaboration. Here are some examples, action steps included in the plan that address this endemic. We included information on the timeframe, federal and non-federal partners involved, which indicators the action step aligns with, and the funding mechanism. We hope this plan will help identify gaps and areas for collaboration and guide policy at both federal and non-federal levels. Finally, I wanted to end to say that our work is not done with development of the National Strategic Plan and Federal Implementation Plan. We are now coordinating a federal syndemic steering committee, which will meet regularly to review and report on progress and identify cross-agency policy and programmatic opportunities for collaborative syndemic approaches. So thank you so much for your time.
Thank you, Jessica, for the presentation. It's really good to see this great experience of cross-sector collaboration and how interested is the work of the federal government. We know that the US has a very unique health systems, and it's interesting to see how the federal government is working on a integrated syndemic approach, not only integrating HIV, STIs, and hepatitis, but also mental health and substance use disorders. So they are a strong determinant for the infection. So thank you. And also perhaps during the discussion, I'd like to hear more we can discuss more on how the federal government is planning on to engage other actors, especially at the state and local levels, to also to start implementing the activities. But thank you. And now, thank you, the presenters, for the presentation, the speakers for the presentation. I think we have some time now for a few minutes for the Q&A and for discussions. And I would like to hand over to John again so he can start the discussion. Thank you.
Okay, thank you. Well, let's get going in that regard so we can get questions to every presenter. And thanks again for excellent presentations to all. Let me cycle back with Carlos just to bring back up the questions that came to mind for me to get things going regarding two aspects. One was the catch-up vaccination strategies for this population, and then two, how did you continue to scale up hepatitis B testing, for this target population? And a question I would like to have for Guyana as well, that because Dr. Anthony brought it up, was how did the response to COVID change the capacity to provide diagnostic testing? I would like to, so if you could respond to those questions, Carlos. Thank you.
Gracias por la pregunta.
Thanks for the question. When we were able to intervene in the populations in remote areas and indigenous populations that have a form of understanding health differently and a different language, what has served us, has helped us, is using a tool that is called intercultural dialogue. Is to generate a space where we have a direct relationship with the chiefs of the communities that we call them APCOs. And so at the beginning, we can provide basic information of what the disease means and what we want to do. I share with you that vaccination is an intervention that has a lot of resistance in the indigenous communities due to different reasons. But in this space, I think we can generate enough interaction and confidence to be able to continue and make progress. Thanks to the intercultural dialogue, we were able to improve in the vaccine process. We have indicators from 2016. We have a recovery index since then for children under 10. So that ensures that they will be free of hepatitis. And this tool that we use to do the screening is the quick test with the health teams that visit the community using the strategy of tracking and visiting the different homes. I think these are the most important strategies that we have implemented. Thank you.
Thank you. And the capacity for testing coming from COVID-19 response, please.
Yes, thank you very much, Dr. Ward. I would want to say that well, first of all, let me give some background. We have about 760,000 people in Guyana. We have 10 administrative regions. In 4 or 5 of them, we have the majority of the population. And those are more easily accessible. So the systems that we have in place works adequately for the majority of the population, let's say about 80% of the population. Our challenge comes in when we have to go to some of the remote areas. And in some of those areas, diagnostic testing was not readily available. With COVID, however, we were able to buy a lot of laboratory equipment, place them into these facilities. And now I think we can repurpose them to make sure that we can test for a wider variety of infections. So it's not only for COVID, but we can do TB, we can do hepatitis and so forth. So I see that as a positive where we're repurposing the equipment to do that. And in addition to that, we have purchased rapid kits where we will be able to go out to some of the remote areas and do testing as well. So I think expanding the program, going to high-risk areas, having a more focus, having better surveillance would certainly help us as we move this program forward. I don't think we had that focused approach, but over the last several months, we have been working to do that, and especially with Hep C, because we have been diagnosing people with Hep C through the transfusion program, but there was no treatment available. So we want to change that from this year.
Thank you. I and the coalition are very interested in identifying countries that can be case studies of how the COVID response can help hepatitis elimination by building capacity, such as the diagnostic testing that you're mentioning. So I'd like to cycle back with you and explore that further with you if you were open to that.
Sure, let's have that conversation. I'll be happy to do that.
That'd be great. Thank you. Leandro, I think we have a question from the participants, please.
Yes, we have a few questions also for Guyana. So let's take this opportunity since the minister is there, because the audience would like to hear more on the collaboration of civil society in Guyana and how perhaps the experience from the other groups working on HIV could also be support the response to hepatitis. Thanks.
So through our HIV STI program, a lot of the program, the services that we deliver is through the public health system. But we also partner a lot to reach a niche population through civil society. Civil society is involved with us. We have the National Coalition Committee that it's an umbrella body of a number of civil society organizations, and we have been working very closely with them. So they're able to extend our reach. And I think we have worked very well together. Our HIV response, and I think, have helped us over the years to build very strong partnerships with civil society. A lot of our civil society organizations had depended on funding from international bodies, and especially the Global Fund, but a number of these institutions are now in transition. They're transitioning out of Guyana. So I think there are going to be some challenges for these organizations to sustain themselves. As a government, we have been working with them to see whether or not we might be able to help through social contracting. So this is one of the ways that we think we can continue to help civil society organizations that bring value to the table. And so this is an ongoing process that we have.
Thank you, Dr. Anthony. And another question, from the audience regarding the use of the role of telemedicine for treating and testing and treatment for care for hepatitis B and C. And perhaps I would like to direct these questions to some, perhaps we could start with Mexico and Dr. Alexi, if you could address this, the role of telemedicine, especially considering now the pandemic and how the health systems are evolving. And after Alexi, perhaps we could hear from Dr. Benitez as well from Peru. Alexi, please.
Yeah, I think it has been a fundamental part, especially because we changed from specialized centers to a primary healthcare approach. So every single center now has participation with telementoring. So we have gastroenterologists, infectious diseases, mental health and addiction specialists guiding these primary healthcare physicians and trying to increase their capabilities as well to respond. So whenever they have a case that they consider difficult, we immediately engage them to this regional or the state telementoring for discussing the case. But also the online platform has been extremely important for us. So the registry that we have created has has the capability of blocking some process. So if something is wrong with a lab, etc., it won't let the physician to continue to provide a treatment. And that means that, and they know because they've been trained on that if they have that, they need to call us for knowing what's going on and to help them to understand why a patient with APRI or with a certain renal function needs to be treated differently.
Thank you so much for the response. So we can now move to Dr. Carlos. Si podrías, por favor, comentar sobre el rol de telemedicina.
Dr. Carlos, if you could share about the telemedicine focus, what would be the application on this in the Andean region and for those populations that have difficult access, which is common in your region? Thank you, Leandro. I agree that during the pandemic, in the critical moments, during the attention of COVID cases, telemedicine converted into a very valuable tool. We are in Peru reducing COVID cases, and although telemedicine continues, I believe that is oriented for monitoring now. For those cases that have been evaluated initially, through on-site attendance or care, we need to analyze that in our idiosyncrasy. On-site is inevitable, at least when we begin treatment. Yes, it could be a tool that is going to be here to stay, of course, but we need to provide the adequate role that it's more on the monitoring side and the people that provide follow-up. A problem that we have had on the region that are farther away is the connection in Amazonia and certain Andean regions. The connection is not good, very poor connection. So telemedicine there has had an important limitation during the pandemic, and it's a challenge that we need to overcome in the future. Thank you. Thank you, doctor. Now a question for
question to Jessica in the USA regarding, as I mentioned, perhaps you could mention more on how the federal government is planning on the engagement of local and state actors on this, the response, and what has been the participation and the engagement with the civil society in the development of this federal and national plan. Over to you, Jessica.
Yeah, thanks for that question. So as mentioned during the presentation, of the formal route to receive input was through our listening sessions and through public comment in the Federal Register. But we have, ongoing meetings with local and state organizations, public health organizations that they can share barriers based on the ground, challenges based on the ground. We used to have this program called the Hepatitis C Medicaid Affinity Group that our office coordinated, where we worked with state public health and Medicaid offices to develop action plans to address hepatitis C among Medicaid beneficiaries. And then we also work with all of our other federal partners, such as US CDC, who have a number of programs learning collaboratives where they work with state health departments to share strategies to develop elimination plans. And we learn from all of our federal partners. We meet regularly through a viral hepatitis implementation working group, where we can share some of the challenges faced from our partners on the ground. And then working with civil societies as well. We have open email and phone, so they are always welcome to contact us.
That's great. Thank you, Jessica. A couple of questions for Paolo. I raised a question, Paolo, about some of the benefits of this multinational collaboration. Just wanted to make sure that we were, recognizing some of those opportunities. So if you could review those for us, I would appreciate it. Paolo, are you still there?
Yeah, I'm here, John, just that I have some connection issues. Can you please repeat?
Sure. Just wanted to ask you to highlight some of the benefits of over and above planning and sharing lessons learned, which was evident. Are there some other implementation benefits that come from this multinational opportunities, such as preparing educational material that's social and culturally appropriate to populations shared by the countries, or lowering the cost of commodities through bulk purchasing, or leveraging national investments with this catalytic funding coming from the HEP fund, please?
Thank you very much. Yeah, we think that the common ecosystem of the countries of the Andean region is maybe the most important enablers, because we have two types of population. One is the indigenous in the Amazonic, and the other one is the indigenous in the Andean mountains. And really, what we could do among the country is create a platform using the Commission for HIV and Hepatitis as the main entity to share and to create opportunity for horizontal cooperation. So the presence of the committee in a very specific ecosystem, the presence of ORAS CONU, which is the organization of the Andean country, the presence of the sub-regional program of PAHO, WHO, these were really very powerful enablers in order to create the opportunity for sharing and having horizontal cooperation. The communication, as before also was highlighted by Dr. Carlos Benitez, is also possible because there is a methodology of intercultural dialogue that makes it a little bit easier to communicate and to have this logic of working on languages and on cosmovision of the populations. And this really facilitates a lot the work, especially when we have the leaders of the indigenous population well acquainted on the objective of the project, then this makes really the situation quite easy in terms of, or easier in terms of creating those opportunities. So I think that this, just to be very short, is my first reply.
Thank you. Quickly, for let's say, the program has got off to a great start and is really growing in a very positive direction. And really, for me, it brings to mind what was the motivation of the national government. We heard from Peru, there was an outbreak from civil society concern, response to the WHO goals. In the case of Guyana, a funding opportunity for the Andean region. What do you think were the key facilitators of the national government going in this very positive direction?
I think was the optimization of.
I think that.
Can you hear me?
Yes.
Perfect. So I think it was the experience that we had with the HIV optimization treatment. So after we went through the same 3 stages, we saved around $100 million US, and we were able then to have that financial bucket to use in another disease. So we decided to focus on hepatitis C, as we thought that as being the 4th cause of death, the liver diseases in Mexico, before COVID, of course, we needed to invest in that. And having the experience with HIV helped us to understand that we were paying a similar amount of money, treating just few patients instead of focusing on a public health problem with these strategies. So it was more of having a public health focus rather than a specialized focus.
Thank you. Leandro, I'll turn it back over to you, please, for some additional questions from yourself or from the participants, please.
Thank you, John. I guess we have time for one more question, and perhaps I would like to make this question to Jessica, and because it was also expressed in her presentation, but if there's been focus on the plan in the LGBT community and other minority groups, and including access to understand their needs, specific needs of this group. So if you could also expand on this, Jessica, thank you.
Yeah, LGBTQ were included in the plan, not as a priority population, but we did identify that there are higher risk for acute hepatitis B and hepatitis C in this population. So the priority populations were based, those are the disproportionately impacted groups in our plan, were based on national data. So this isn't for all jurisdictions in the U.S. So, we have state health departments that are developing their own elimination plans. So we encouraged all of jurisdictions to look at their own data to identify which populations to focus on in their jurisdictions. And so, this is national data, which we know that there isn't, for the US, a great surveillance system available yet. So it's based on the best data that we have.
Thank you. Thank you so much, Jessica. I don't think we have time for more questions. So I would like to thank you, all the speakers for the time, for the great presentations, and also all the audience for the questions and the interactions. And I would like to, again, back to John, so you can close up the session. Thank you, John. Joe, sorry. Back
I
to
just
you.
want to thank everyone. Yes, just thanks again, Leandro, for being part of this session, working with you and PAHO and the countries that are represented here today and the others in the region. It's been a very productive collaboration. A lot, as you can see from this presentation, a lot of very good activities underway to accelerate progress toward hepatitis elimination in the Americas. And I think we'll be turning it over to the next session that Sue Wong and Sergio Sosa Estani will be moderating.
Thank you, John. Thank you so much, and my great pleasure to be part of this event. Thank you for the organizers, and my pleasure to co-chair with Sue this session. I would like to invite Sue just to say hi at this time, and then we will follow with the presentation.
Sure. I just want to thank the organizers for this session and the second part of the session, which is focused on experiences from the civil society. As Patricia mentioned, with her great work that she's done in Guatemala, in Latin America, this is such an important part of us getting to elimination in national responses too. So I think we'll be really excited to hear about the work of civil society in the next couple of presentations. And I will hand it back to Sergio to do the introductions. Thanks.
Okay. Thank you, Sue. And I will take advantage that there will be simultaneous translation just to switch to Spanish, considering the session. Bueno, muchas gracias nuevamente.
Thank you very much. In this panel, we have excellent speakers, and I want to initially invite the first speaker, Victoria Izquierdo, from the organization Civil Society Hepatitis C, Uruguay, to present the experience of the civil society in Uruguay. Hi to everybody.
Good morning. I'm really glad to be here today, presenting the experience carried out
talking about the experience
in Uruguay by ACHCU, Asociación Comunidad Hepatitis C Uruguay, to whom I represent, and my name is Victoria Izquierdo. Understanding that my presentation is a Latin American experience, and probably most of the people attending here are also Latin American, I will respect my regional colleagues and go on with it in Spanish. Bueno, buenos días a todos. Uruguay es un pequeño pero gran país al sur de Sudamérica,
Uruguay is a small but great country with 3.5 million inhabitants. It is classified as a high-income country since 2013. We still do not have complete scientific information on the prevalence of Hep C, only based on data extrapolated from the regional areas with Argentina and Brazil, which estimates 0.5 to 1.5%. The current history of hepatitis hepatitis C in my
vinculada
country
a
is
la
directly
organización
linked
de
to
pacientes
the
ACHCU,
work of the
que es
Association
quien
of
logra hasta el
Patients,
momento y los
ACHCU,
importantes
who
objetivos
has
alcanzados
achieved
cuando no existían
important
políticas para
objectives
hepatitis C.
when there were no policies
Cuando
for
por primera vez
hepatitis C.
conocí a este
When
grupo de
for the first
pacientes,
time
mis
I met
actuales
this group of
compañeros y con quienes
persons, my
finalmente
current colleagues and with
conformamos la
whom we
organización,
created the
algunos de ellos estaban
organization,
realmente muy
many of
enfermos,
them
luchando
were
por sus
very
vidas
sick,
y venían desde
fighting
el
for
año
their lives.
2014
Since
realizando
2014,
denuncias
they had
y
been
reclamos
working,
ante la
filing
Institución Nacional de Derechos
complaints
Humanos,
to
el
the
Ministerio de Salud
Office of Human
Pública,
Rights, the
el
Ministry of
Parlamento,
Health,
la OPS
the
Uruguay
Parliament,
regional e
PAHO
incluso la
Uruguay,
Corte
and PAHO
Interamericana de
Regional,
Derechos Humanos.
and even all the
Algunas
way
de
to
esas
Inter-American
denuncias
Court of
aún
Human
continúan
Rights.
abiertas,
Some of
otras,
these
como la
lawsuits
Institución
are
Nacional de
still
Derechos
open,
Humanos,
and
falló a
others,
favor
like
de la
the
sociedad
one
civil
to
con
the
importantes
human rights,
recomendaciones para el Ministerio de Salud
has been
Pública.
resolved and issued
Para el año
important
2016,
recommendations to the Ministry of
debido al
Public
alto
Health.
costo de los
By
antivirales de acción directa que
2016,
estaban
due to the high
disponibles
price
en el
of
Uruguay,
antivirals of
el Estado
direct
uruguayo
action available in
únicamente
the
entregó
country,
19
the state of
tratamientos
Uruguay
con un
only
restrictivo
delivered
criterio de
19
inclusión
treatments
que se acotaba a
based on a
personas en lista de
restricted
trasplante,
inclusion criteria
lo que
and,
propició una
only
catarata
for
de
patients who were
quejas legales
undergoing a
contra el Ministerio de
transplant.
Salud Pública.
This situation triggered
Es
a
así que
wave of legal
resolvimos fundar la
complaints
sociedad
against the
civil
Ministry of
e
Health. That is when we
incursionar en la
created our
importación de
civil
antivirales
society
genéricos,
organization to
importando
look
a
into
uno
importing
bajo una
generic
normativa del
medications. We
Ministerio que
started
permitía
importing
importar
them one by
cualquier
one under
antiviral
a norm by the Ministry of
genérico
Health
que
that
no estuviera
allowed
aún
the
registrado
import
en
of
el país.
generic antivirals that
Y
were
nuestra
still
experiencia
not
fue
registered
enriquecedora. Muchas
in the
personas,
country.
dentro de las cuales me
It was
incluyo,
an enriching
logramos
experience.
curarnos
Many
gracias a
persons,
esa
including
práctica y
myself,
sentar a su vez
were
las bases
cured
de lo que estaba
and
por venir.
established the foundations of what was to come.
Para el año 2017,
By
ante la vulneración que
2017,
considerábamos era la falta de
because
acceso
we
universal a
faced
estas
what we consider
medicinas,
violation to
resolvimos
our right
iniciar
to
una
universal
política
access
de
to this
genéricos.
medication.
Y
We
apoyados por la
decided to
Clínica de
draft a
Farmacología
policy
de
of
la
generic
Universidad de la
drugs,
República,
supported by the Pharmaceutical
participamos del World
Clinic
Hepatitis Alliance Summit
of the National
2017,
University,
donde
University of the
concurrimos para
Republic. We
consolidar y concretar
participated
acciones
in the World
que nos
Hepatitis Alliance
permitieran
Summit in
traer
Sao
los antivirales de
Paulo,
acción
where
genérica
we
a
learned
nuestro
ways to
país para su
implement and
registro.
consolidate
Quizás
actions to
algunos puedan
import
reconocer
and
ciertas
register
imágenes.
generic drugs, generic
De forma
antivirals
paralela y
into our country.
concomitantemente,
In
nuestra organización había
parallel, our
comenzado el camino de la
organization
búsqueda
started to
de los
seek for
pacientes,
persons for
realizando actividades
screening
de
with
cribado,
screening
como la de
activities
la cárcel de
like the one
Comcar,
in
una
the
población de
Comcar
4.000
jail
reclusos, la cual
with
pudimos llevar
4,000
adelante gracias al
inmates,
apoyo de
where we
Cero Brasil.
conducted rapid testing for
En el año
HCV
2019,
virus,
las
for the
acciones
HCV
llevadas
with the support
adelante
of
para el
Hepatitis
registro
Zero
de
Brazil.
la medicación
In
genérica
2019,
se
we were able to
consolidaron
consolidate the
y
actions to
permitieron que Uruguay
register generic
pueda
drugs
contar
and
con medicación
allowed
asequible
Uruguay
para
to
quien la
count with
requiera
medications
y que
for
es provista por el
hepatitis
Estado
free of
uruguayo de
cost,
forma gratuita
provided
para
by
todas
the
las personas
state to
afectadas por
all
hepatitis C.
affected persons by
El Fondo
hepatitis
Nacional de
C.
Recursos, que es el organismo
The
estatal
National
que regula
Resource
los
Fund, which
medicamentos
is
en
the
Uruguay,
state institution that
modificó
regulates
la
medicines in
restrictiva
Uruguay,
normativa que tenían los
modified
medicamentos de alto
restricted
precio
guidelines for the high
e
cost of
incorporó estos
medications
antivirales
and
de acción
incorporated
directa
these
genéricos, ampliando los
antivirals, these
criterios de
generic
inclusión para todas las
DAAs,
personas afectadas
and
desde F0 hasta
flexibilized
F4.
the criteria to
En tanto, la
provide
sociedad civil,
medications to
nosotros
all persons
continuamos
affected by Hep C. As a
trabajando
civil
en lo
society, we
que se
continue
refiere a la
to work
simplificación de los
on the
criterios de diagnóstico también
simplification of
en
the
las cuales
criteria for
encontramos.
diagnosis.
Uruguay no cuenta aún con un
Uruguay
programa
does
de
not
hepatitis crítica
have
nacional
a
ni un programa
specific hepatitis
específico
program
y fue
or a
entonces nuestra
national
tarea
hepatitis program.
sensibilizar
So
y
it was
exigir
our task to
soluciones en
create
ámbitos
awareness and demand for
ministeriales, en
solutions
ámbitos
among
políticos y
stakeholders
comisiones
like the
de derechos
ministries,
humanos y de salud del
Health
propio
and Human
Parlamento.
Rights
Tenemos
Commissions
muchas
within the
demandas iniciadas,
Parliament.
algunas de ellas
We
ya
had
con
several
resultados,
ongoing
otras en
lawsuits,
curso.
some which had been
Creamos
resolved
vínculos
and
con la
others still in
academia y con los
process.
médicos para
We
que se
established
unan
links with the
a la tarea
academia
y
and
también
with
para facilitar su
physicians to
participación
bring them
e
on
inclusión
board
en
and to
estos ámbitos
facilitate
de
their
decisión política.
participation and inclusion in
Para
political
consolidar y
advocacy.
promover un proyecto
To
nacional fue la
consolidate
propia
and promote a
organización de
national
pacientes
invitation, it was the Patients
tomó iniciativa
Association,
creando su
which
propio programa
once
de
more took the
erradicación, que
initiative
se
to
denomina
create their
Uruguay sin
own
hepatitis C,
eradication
que fue
project
declarado
called
de interés
Uruguay
ministerial,
Without Hepatitis C,
comenzando
which
una
was
campaña de
declared a
cribado
ministerial
en diferentes grupos
interest.
poblacionales de
One
forma
of their initial
independiente,
activities was to launch
luego,
a
producto
screening
de las
program on
campañas de
diverse
sensibilización y
populations
advocacy,
independently. As a
consolidamos
result of the
acuerdos
advocacy and
con
awareness
gobiernos
campaigns,
departamentales
we
como el de
subscribed
Canelones
agreements with
y también
departmental
con el de
governments like
Montevideo, que
Canelones
adhirió al
and with
programa en
Montevideo,
conmemoración del 28 de
the latter one
julio
during the
del año
project in
pasado.
June 28,
Se
2021,
impulsaron
last year,
programas de
for the
microeliminación,
celebration
como
of
el de
World
Seremos,
Hepatitis
una
Day. We also
institución de salud
implemented
mental con
microelimination
altísima
programs like
prevalencia
the
dentro de
one
sus
in
internos,
Seremos, a psychiatric hospital,
donde
which
bueno,
had a
logramos hacer
very
la
high prevalence
microeliminación
among
dentro de esa
inpatients. We were able to
establecimiento.
achieve
Una gran
microelimination in
preocupación para
this
nuestra
center.
organización,
A great concern for
conformada por
our
pacientes o
organization,
infectados con VIH, tiene que ver
comprised by
con la de promover el tratamiento dentro de nuestras
persons with
poblaciones.
HIV,
Por lo que
which has
nos hemos
members with
centrado en
HIV,
llevar
was to
los
promote
reclamos a la
treatment for this
Comisión Nacional de Lucha
population.
contra el
We
SIDA
brought our
y
concerns to
hemos
the National
realizado
Commission
campañas de
Against
cribado
AIDS,
dentro del
and
Centro de
since then we
Referencia
have
Estatal.
conducted screening campaigns in the
Producto
State Referral
de esas
Center.
actividades,
As a result of these
logramos promover
activities,
la reapertura de un
we were
policlínico con un
able
área
to
específica para
open a
hepatitis vírica en el
hepatology
Hospital Pasteur,
clinic inside
involucrando
the
y comprometiendo
Pasteur
en
Hospital,
estas políticas
and we
de salud a
engaged
importantes
and
autoridades
sought
sanitarias.
commitment from the
Como
health
se,
staff and
como se
important
mencionó anteriormente, las
sanitary
campañas de cribado y
authorities. As we
sensibilización fueron
mentioned
llevadas
before,
incluso
the
al propio
screening
Parlamento
campaigns
uruguayo, al
for
Parlamento
creating
Nacional.
awareness were
Este
undertaken at
año
various
hemos
levels,
logrado un
including the
importante
Uruguayan
acuerdo de
Parliament.
carácter
This year, we have
internacional
been able to
con
subscribe
el
an
objetivo
important
de poder
international agreement
concretar y
with the
materializar
objective of
una
making a
acción en
reality
específico que es
a
convertir a
specific
Canelones, el
action
departamento de
to
Canelones
declare the
como
municipality
municipio
of
del
Canelones
Uruguay,
free
a
of
transformarlo libre de
hepatitis C.
hepatitis C. Es así que en un compromiso de
In
Ciudades
this
Libres,
regard,
City Free
in
España,
a
firmamos un acuerdo
commitment
con el
with the
gobernador y
governor
la
and health
directora de salud de
director
ese
of this
departamento, de ese
municipality
municipio,
in a
y
CHCU,
AEB,
subscribed an
la Alianza
agreement
para la
with the
Eliminación de las Hepatitis
initiative
Víricas en
Hep
España,
C-Free
con el
Cities
apoyo
and
de
the
la Clínica de
Alliance for the Elimination of
Gastroenterología
Viral
y
Hepatitis Spain,
Farmacología y
with
Terapéutica
the
de la
support
Universidad de
of
la
the
República,
Gastroenterology and
en este
Pharmacology
ambicioso
Clinics of the
proyecto que
University of
esperamos
the Republic.
materializar e ir
We
sumando
hope to
nuevos
transform this
municipios
ambitious project into a
con
national
la idea de poder
program,
transformarlo en un programa
expanding
nacional.
it to
La
other
World Hepatitis Alliance
municipalities.
acompañó
The
esta
WHA
iniciativa.
has provided support for this initiative.
Como parte del programa Uruguay sin
As
hepatitis
part
C, se
of
inició
the
además un
work,
trabajo de investigación con
we
el
started
fin de
an
recopilar
investigation
datos sobre diagnóstico de hepatitis
research,
C y
a
hepatitis
research
B,
program to compile data on
así
hepatitis
como
C
las
and B
tasas de
and
mortalidad
related
vinculadas.
mortality rates.
Este trabajo se desarrolló
This
con el fin de
work
identificar a las
was
personas
developed to
ya
identify
diagnosticadas
persons
y también
that
con el
had
objetivo
a
de reforzar
hepatitis
la obligación de
diagnosis,
informar
and
procedimientos de
also with the
notificación
objective of
obligatoria al Ministerio de
reinforcing the
Salud Pública,
mandatory
otra
reporting
incidencia
to
de
the
la sociedad
Ministry of
civil,
Health,
que en el año
following
2018
another
logró
achievement
que
of the
la
civil
obligatoriedad de la
society
denuncia pasara a
that
ser
in
responsabilidad
2018
de
was
los
able to
laboratorios de
shift the
análisis clínico y no del
responsibility
médico
of
tratante,
mandatory reporting
como venía
from
sucediendo.
physicians to the clinical labs, as used to
HHCU
be the norm.
se está valiendo de la ley de acceso a la
CHCU
información
is
pública que
carrying out
rige en nuestro país
research
como
to
una
collect
herramienta para la
data
recolección
on
de
hepatitis
datos
C
y
and B
también
using
pensamos
the
que el
access to
programa
information law
Epsitify
together with
Canelones
data
para la
generated by
recopilación de datos
Canelones
que esto va a
project to
acarrear
characterize the
permitirá
magnitude of the
desarrollar un
problem.
trabajo de,
With,
de
with
investigación
this
epidemiológica para
with this
contextualizar la magnitud
work,
del
we
problema.
would be able to
Con esta presentación queríamos
dimension
exponer
the
el
problem.
trabajo
With this
diario de los últimos
presentation,
años en la búsqueda del
we
compromiso
wanted
de
to
nuestro
disseminate
gobierno
our daily
con el
work
que
during the
aún debemos
past
ser
years to
críticos.
advocate
No hemos logrado los
for
objetivos
to our
de la
government and
declaración
continue
que
to
formamos en el año
expose that we
2017
have
en el
not
Summit de San Pablo,
and continue
en la que
to say
exigíamos
that
a
we
los
have not
gobiernos que
fulfilled the
den,
objectives of the 2017 agreement,
que
the
den a las
Sao
hepatitis
Paulo
virales la misma
Summit,
prioridad que
and
el VIH,
we
SIDA, la
demand
malaria y la
the
tuberculosis.
governments to place viral
No hemos
hepatitis at a
logrado
similar
que se
level of
incluya dentro de las
priority
metas asistenciales
as
de nuestro país a las
HIV, TB,
hepatitis
and
a las
malaria. We have
viríricas,
not been able
y no hemos
that the
logrado
government
el
includes
inmediato
viral
tratamiento
hepatitis in
de
the
los más
national health
infectos
targets,
que hemos
and
logrado
we have not been
identificar
able to achieve
que
immediate
están en el
treatment to
sistema de
more than
salud
the
y
300
por los que
patients
estamos
that have been
abogando. Otro
identified
elemento de
in
gran
in the
preocupación que
health
revelan las
system. Another
estadísticas
concern is the
es la gran
large
brecha
gap between
entre paciente
diagnosed
diagnosticado y paciente
a large
tratado,
gap
que
between
se ha
diagnosed and
profundizado
treated
aún más
patients,
con
which
la
has
pandemia.
widened due to
Pero
the
para finalizar
COVID-19
con,
epidemic.
con
To wrap
novedades
with a positive
alentadoras,
note,
el año pasado el
last
Ministerio de
year,
Salud
the
Pública
Ministry
nos
of
invitó a
Health
participar
invited us
de
to
la elaboración de las
participate
primeras guías
in
nacionales de hepatitis
writing
vírica,
the
las cuales estamos
national
esperando con
guidelines for viral
ansias
hepatitis,
y serán
which we
emitidas
are
con motivo
hoping
del
to
próximo
have
28 de
soon
julio.
and are due
Para
to be
despedirme,
released in June
quisiera
28th.
expresar mi
To
más grande agradecimiento
say
a todos
goodbye, I
quienes a lo
want to
largo de
express
estos
my
años han trabajado,
gratitude
han colaborado
to
con gran
all the
esfuerzo,
persons that
codo a codo
along these years have worked with great commitment and effort. And so I greet you all and thank you very much. Thank you very much, Victoria. Excellent presentation. It was clearly proved the experience of Uruguay and that with demanding to the governments, we can get responses, and it has more strength if it comes from the people that are affected by the disease and from the civil society. So now we'll go on to the next presentation. Thank you again, Victoria. now we're going to Eugenia de Fao Moyano. Please, María Eugenia, go.
Hola, buenos días. Mi nombre es Carolina Meijón. Soy de la Fundación HCD Sin Fronteras. Muchísimas gracias por este espacio para poder compartir este trabajo que expone la elaboración y la presentación del proyecto de Ley Nacional de Respuesta Integral al VIH, hepatitis virales, tuberculosis e ITS, escrito en su totalidad por la sociedad civil de personas con hepatitis virales y VIH. Este proyecto, una vez convertido en ley, será faro no solamente en nuestro país, sino también en la región y en el mundo. Busca mejorar la calidad de vida de las personas, garantizar el acceso a la salud integral, garantizando el acceso efectivo y el ejercicio cotidiano de las políticas públicas. El objetivo fundamental es lograr un marco legal que contemple la respuesta integral a estas enfermedades. Ahora bien, que estamos hablando de respuesta integral. ¿A qué nos referimos? Es integral porque da cuenta de una mirada biopsicosocial de la persona. Esto es tener en cuenta no solo su condición de salud, sino los determinantes sociales que están implicados. Una respuesta integral es prevención, es acceso a un diagnóstico oportuno, es investigación, es tratamiento, es cura, implica procesos de rehabilitación, cuidados paliativos, reducción de riesgo de daños, como así también el abordaje y la eliminación en el estigma y la discriminación. Es pensar a la persona que padece una condición de salud determinada como un todo y no como un mero hígado enfermo. Bien. ¿Por qué es importante una ley de hepatitis virales en nuestro país? En nuestro país, con los cambios de gestiones políticos, no siempre están garantizadas las estrategias de políticas públicas. Las hepatitis virales son de interés nacional en la actualidad, pero pueden dejar de serlo. Por este motivo es necesaria una ley aprobada por el Congreso que garantice los logros alcanzados para la lucha de las hepatitis virales y que no queden a expensas de las meras voluntades políticas de las gestiones. En la Argentina, 400.000 personas podrían tener hepatitis B o C, pero más del 50% no están diagnosticadas. Según los datos del Boletín Epidemiológico del Ministerio de Salud del 2019, fallecieron 5.000 personas por consecuencias relacionadas a la hepatitis B y C, pero estos datos muestran solo una parte de la realidad. En la actualidad contamos con vacuna para la hepatitis B y tratamiento de acceso universal y gratuito para la hepatitis B y C. Si bien contamos con los tratamientos gratuitos y universales, aún hay muchas barreras en las que trabajar. Entre ellas tiene que ver con el diagnóstico oportuno, por supuesto, y esto trae consecuencias con el tratamiento y la posibilidad de la cura para evitar cualquier muerte totalmente evitable a estas alturas. La estigmatización y la discriminación es una realidad tan silenciada como estas enfermedades, y por lo tanto nadie puede quedar fuera y todos tenemos derechos a una salud. Un poco de la historia de este proyecto. En el 2009 la Fundación HCD Sin Fronteras presenta un petitorio en el Congreso Nacional pidiendo una ley nacional para las hepatitis virales. En ese momento, bueno, no fue tenido en cuenta. Hace 8 años, por iniciativa de la comunidad organizada de personas que trabajan con VIH y hepatitis virales, en conjunto con aquella gestión del Ministerio de Salud de la Nación, se comenzó a trabajar en un borrador que modificara la Ley Nacional de SIDA vigente, la 23.798, pero que también incluya a otras enfermedades que no están incorporadas en el marco normativo. Estas enfermedades son las hepatitis virales, la tuberculosis y la ITS. Este proyecto de ley fue presentado en 4 ocasiones, la primera en el 2016, 2018, 2021 y en marzo de este año. El 29 de marzo se presentó públicamente en la Cámara de Diputados, en un acto en donde 14 representantes de distintas organizaciones civiles y representación de más de 200 instituciones, leímos un escrito que daba cuenta de la importancia y la necesidad de que esta ley fuese tratada. En la lectura estuvimos acompañados y apoyados por los distintos diputados de los bloques firmantes, como así también por el Poder Ejecutivo, a través de distintos organismos del Estado, el Ministerio de Salud, el de las Mujeres, Género y Diversidades, INAI, ANSES y
and
también
by
fuertemente
representatives
apoyados
of
por
the
Naciones
Ministry of
Unidas, representados por Alberto
Health,
Estela, director de UNCIA
universities,
para
and
Argentina,
strongly
Paraguay,
supported
Uruguay
by the
y
United
Chile.
Nations,
Y al día de la fecha, bueno, estamos a la espera
represented by
de
the
que
director
esta
of
vez
ONUCIDA,
sea la última
UNAIDS, and
presentación.
currently we
Bien,
are awaiting
¿cómo lo
that
hicimos?
maybe this would be our
Bueno,
last
fue
presentation
un
and then we will finally have
trabajo,
this law
bueno, viene
approved.
siendo un trabajo
So
de
how
8
do we
años
carry
en
out this
donde
work?
la pandemia no
It,
nos frenó, donde trabajamos
it's 8
en equipo
years.
interdisciplinariamente,
The pandemia did not
transdisciplinariamente y
stop us. We worked
multidisciplinariamente.
as an interdisciplinary team and
Llevamos a
transdisciplinary
cabo
team and multidisciplinary.
encuentros de
We
manera virtual con,
implemented
con diputados, con
virtual
representantes de diferentes
meetings
agencias
with
nacionales
the
e internacionales.
congressmen, representatives of different national and international agencies.
Bueno, el Zoom ha sido una gran herramienta y un gran amigo en todo este tiempo y un gran posibilitador
and a great
de
friend
poder
throughout this
redactar,
effort,
¿no?
and has enabled us
este proyecto.
to draft,
Durante toda la pandemia
write
nos reuníamos
this
todos los
project.
domingos, mínimo 4 horas,
During the
para poder
whole pandemia,
elaborar
we
este
would meet
proyecto
on
en donde
Sundays, at
fue un
least for
trabajo de
4
gran consenso, de
hours,
gran
to be able
responsabilidad
to
en cada
draft
palabra
this
escrita.
project,
Se
which
debatió
was
cada uno de los puntos
a
y
great
coma
consensus, a
de
great
todos los artículos que
responsibility in every
componen
written
este
word.
proyecto.
We have discussed every
Fuimos
period and
entrevistados
commas
por
of this
diferentes
project was
medios,
discussed.
nuestras
We
voces
were
fueron
interviewed by different media.
escuchadas y fueron compartidas en
Our
los diferentes medios
voices
gráficos.
were heard and were
Las redes
shared
han
in the different
sido
written
un
media.
recurso más y un medio más.
The social
Redactamos
networks
cartas
have
a
been
los legisladores, incluso
another
al
resource.
presidente de la Nación, pidiendo el tratamiento
Wrote
de este
letters to
proyecto.
the legislators, even to the
Y,
president
por
of
supuesto,
the
salimos a la
republic,
calle a
demanding
alzar
the
nuestra voz,
approval of this project.
a
And of
ser
course,
escuchados,
we
pero
went to
también
the
a seguir
streets,
visibilizando
we
la realidad de las
elevated our
hepatitis virales y a
voices so that
concientizar
we could
sobre
be
ellas.
heard, but also
Hepar Red
to
Argentina estuvo
continue
presente
to
en todos
visibilize
los
the
diferentes
viral
puntos de
hepatitis and
nuestro país.
create
Y
awareness.
como Sociedad Civil de
Barrera
Hepatitis Virales
Argentina
ha sido un
was
trabajo muy
present,
rico y de gran aprendizaje junto a todos los
and
colectivos de
it has been a very
las personas
enriching
que viven con VIH.
effort, and we
Ha
have
sido, es
learned
y va a seguir siendo
greatly.
un maravilloso trabajo
We have also been together with
una sociedad
persons living
empoderada.
with HIV.
Una
So
sociedad
it
civil
has
empoderada es un
empowered
componente crucial
us,
para cualquier
and an
sistema
empowered
democrático.
civil
Es un actor
society
esencial en la
is a
participación en la implementación de
essential
políticas públicas
component
que
for
deben
any
abogar por el
democratic
bienestar de sus
system. Is
ciudadanos. La
an
sociedad civil es
essential
clave
stakeholders
en
for
su
implementing
función
public
comunicativa,
policies
sensibilizadora y
that
catalizadora de
advocate
los temas
for
más
the welfare
relevantes
of
y
the
necesarios
society.
que deben
And it is also
estar en la
key
agenda de nuestros
to
países.
for
Dicho todo esto,
communication, for
les comento a modo de
advocacy, and they should be
síntesis
in the
los
agenda of our
temas más
countries. All this said,
relevantes
I
del proyecto que
commend
concierne a las
as a
hepatitis virales. Ahí
summarizing
dice
that the most
proyecto
relevant
004 de
topics
2022, lo pueden
in
encontrar
regard
en
to
la página de la fundación.
project
Bueno,
034
lo googlean
2022,
y
it
va a
can be found
aparecer.
in the internet
Los
site
temas
of
más
the
relevantes tienen que ver
foundation.
con la garantía y la asistencia
And you can Google
sanitaria,
it and
cobertura
you would
médica
find it.
asistencial
The
pública
most
de obras
relevant
sociales y
topics has
prepagas,
been to
la prohibición de obligar a
ensure
las personas a informar o declarar
coverage,
su estado serológico,
and
disponibilidad de
prepaid
insumos, reactivos,
to
tratamientos en tiempo y
obligate
forma, los
the
abordajes
persons
integrales,
to
el acceso a los
disclose their
test diagnósticos
serologic
para hepatitis
state
B y C sin
and
necesidad de una orden
the
médica, el apoyo
comprehensive
legal y gratuito,
approaches
el
and
diagnóstico pre y
the
post-test, las pruebas
availability of
voluntarias, los controles en
tests for
embarazo,
hepatitis
en
B and C
parto, en
without
lactancia para
a
evitar la
medical
transmisión vertical
request,
y la jubilación
and
especial de
also
carácter excepcional
screening
para las
during
personas con VIH,
pregnancy,
hepatitis B
breastfeeding,
o C.
and
Esto es
it
a modo
also
de
take care
resumen.
of co-infected persons with
Este es
HIV
un texto
and hepatitis. So this
que hemos
is
leído.
my summary. This
El
is a
silencio no
text
nombra.
that we have read.
Lo que yo voy a referirme ahora
Silence does not name.
no es específico del texto, pero da
What I'm
cuenta.
going
El
to
silencio no
talk
nombra,
about
no
now
relata, no
is
acerca.
not
La palabra
specific of
informa
this text,
empodera y
but
cura. Y
silence
por tal
does not
motivo es
name, does
necesario que
not
sigamos hablando
narrate
y levantando la voz
the
de que las hepatitis virales
word
existen. Y si hay
empowers,
algo
and
que
that is
hace este
what's
proyecto
necessary
es
to
eso,
be
transforma los silencios
elevating
en
our voices
artículos
that the
jurídicos llenos de
viral
palabras
hepatitis
que reflejan
exists.
estas pandemias
And this
silenciadas.
is what the
Hemos
project
aprendido a
seeks to
trabajar en la
transform
diversidad de
silence
pensamientos, a
into words
consensuar desde la
that
vulnerabilidad
reflect
y la
the
discrepancia.
silence
Hemos
epidemics.
realizado un
We have
proyecto de
been
ley,
able to
ejemplo, que
meet
busca ampliar derechos
consensus
en materia de políticas
to work
públicas y acceso a la
together. We
salud,
have a
centrado en
law
perspectivas de derechos
project
humanos y género.
to
Por
change
primera vez, las personas con hepatitis
public
virales podrán estar amparadas por un marco
guidelines
legal
and
que
laws, and for
garantice
the
sus
first
derechos a
time the
una salud
persons with viral
digna, sin
hepatitis
estar
will be
sujetos a la
protected by a
voluntad
legal
política
framework
de quienes los
that
gobiernan.
guarantees
Por
their
nuestro
life in a dignified
presente,
way
por nuestro futuro
and not
y
subject
para
to
honrar
wavering
a quienes
politics and
iniciaron esta
policies,
lucha, a quienes
and to
formaron parte de
honor
esta lucha y hoy
those
no pueden
who
estar presentes, que
initiated
sea ley.
this
Muchas
fight,
gracias.
who were part of this fight and cannot be with us here today. Thank you thank you, Maria Eugenia, for excellent presentation and to join us in the section for Q&As. The presentation showed how the organizations of civil society doing incidents and advocating in the legislative system. It's not enough only to advocate with the Ministry of Health if there is not a legal framework that guarantees the access and care with quality and diagnosis and treatment with affordable cost, and that can be provided the first level of care. And this has been exemplified in your presentation. So thank you very much for these two initial presentations, and I invite now Sue.
Great, thank you, Sergio. So we're going to move on to our next presentation, and this is actually not civil society, like a community group, but we'll be talking about ALE, which is the professional organization of hepatologists in Latin America. And the medical professionals obviously have a big role in hepatitis elimination. The World Hepatitis Alliance has launched a no HEP program just for medical professionals, and we are honored to have Dr. Marcelo Silva talking today. He's actually one of the no HEP medical visionaries as well, and he'll be talking about a project for microelimination of hepatitis C in dialysis patients. Go ahead.
Good afternoon, everybody. Thanks a lot for the invitation, being part of this important activity. As the previous speakers already did, I'm going to switch into Spanish, understanding that most of the attendees are Spanish speaking, no? Thank you for the time. Como mencionamos, bueno, a ver.
As we mentioned, I am not civil society, but yes, I am. Doctors are part of civil society, and we have the responsibility to fight for those rights that the patients are. So this, and we need the scientific community involved with civil society. The idea we're going to talk is HCCD microelimination in ESRD patients in Latin America and how a scientific community has to involve in this. Next slide. We can continue. Hello. One of the topics that I think is important is that the scientific communities has networking that can help the civil society and the ministry, or what WHO and PAHO can do. It's labor force that gets us closer to the primary care and that allows us to be those that make policies, self-policy. But the network with societies allows us to get closer to the patient, closer, and we can interpret after 40 years of being a doctor that we have not been used as much by the ministries to access the care of the patients with in a more holistic way. In this slide, I want to show you all the other initiatives, network initiatives that we have worked with in Latin American in different topics, in toxicity, in hepatitis, cancer, COVID, and relinkages and in generating information and education through society is a way that we can have democratic access to good care. Of course, it has criticism, and sometimes the patient number is small. But when we see this history of network, we have done a lot of clinical diagnosis. We have worked with more than 4,000 people. It's a door that it's open for the population that sometimes that is difficult to implement. Next. Next. All of you know that the prevalence in HCV in chronic insufficient is superior to in that in general. Because we can see the prevalence in different regions in the world in a recapitulation with 7,000 patients and 6,000, 8,000 patients. And what is the region, and in the region that we research? Why do I want to show the numbers? Because it's the highest prevalence, but those patients are sitting there. We don't have to go and look for them. They have been diagnosed, they have been identified, they are under care, and we are not treating them efficiently. Next. And of course, next, we know it doesn't kill due to its morbid and comortality due to cardiovascular infection, hepatic related diabetes. The impact is not only the high prevalence, it is superior to the population that is not infected to other cardiovascular disease. Having said this, please, the next one. Please, the next one. In summary, we need to go and look for fish this patient. In Argentina, 4% of the populations are infected by HCV, and this is 4, 5, 6 more than the general population. And this has a great advantage because if we have a country that has a health system that is fragmented and that what the ministry decides and a first attention doctor will not do, those patients are already there. So it's easier to focus on this to eliminate Hep C and Hep B in this universe of patients. Next. Next, please. So we have to go to microelimination. That is what the scientific community says. We need to go to this. We need to work in microelimination so they are part of the path of WHO and all the other and want as they. So we can work on elimination of hepatitis, but we need to start working on those places where we have the patients. Next. For the advantages of targeting this patient population, they're obvious because there's a reduction of liver and non-liver related to morbidity and mortality because it reduces the complications that they can have in the post-transplant and in the reduction of morbid mortality during post-kidney transplant. So there are multiple reasons why this patient should be approached with priority, and we can have a better control in the dialysis units with biosecurity and to avoid isolation that is being done with these patients, and also, why not say it, to reduce costs. Next. Next. We have planned a project that has 5 pillars. The first pillar is to have a survey in those and the specialist nephrologists, so they will tell us with those non-specialists if they are interested in getting involved and what barriers do they have. The second one is a pillar in education for those non-specialists, especially in those that have to do with the handling of HCV, prevention of HCV, testing and diagnosis, treatment, and with follow-up of those that are cured. Third pillar is critical, which is a pillar with a registry that will allow us to collect data that is amicable, that can be used in the daily work in the doctors and patients, and with an e-platform that can be accessible in all the region. And then we have, as a fourth pillar, lower the landscape of the project, of the investigation project, and then accountability, the responsibility of civil society, so that we really think and see that we're really doing what we have to do. And next, we're going to go really quickly so we can finish on time. Next, please. This is the survey, if there's interest or not. And a topic that is very important, barriers. We need to learn to identify barriers because they are different in Brazil, Argentina, and Chile, in the Andean region, wherever. The regulations are different. In some countries, like Victoria was explaining, the access in Uruguay, in other is not access, which doctors should prescribe treatment. And indefinitely, what are the limitations that we have as barriers to treatment? Because for a molecular test, we can do it, or do we have to carry on several steps to reach to that treatment? Next. Next. In the non-specialist education project, we have discussed this topic. We have activities jointly with ECHO, and with ECHO, it is really applicable to do a monitoring and coaching or telementoring for those that are non-specialists that are in the dialysis sites that want to treat these patients. It's not complex, it's a Zoom, and what only changes is the dynamic, but what is important so that there's engagement is that we don't have to tell them what to do. We have to be friends with them, work hand in hand jointly, transfer knowledge in a friendly way, and decide what is the best treatment in that side, on that side for that patient. And not only restrict ourselves on the treatment, but the interaction with other drugs and how we can evaluate the degree of fibrosis, for example, that will happen with the patient. So it's education, and it's work to them hand in hand, jointly, to see how we can treat better each patient. And of course, that we cannot forget about hepatitis B and vaccination in this population. Next. Next, please. What we need to see with a registry design and new platform, very simple, has to be friendly. Brazil always, and Mexico, and then after Colombia are having forward steps, making forward steps in our countries. I'm going to talk about Argentina. because it has a different structure in the health system that it makes it to be efficient. But in the registry and the platform, we need to understand who are the leaders in each country. We need to take these strategies and we need to learn from them and need to take advantage of this experience. And the electronic registry is key so that everybody has access to education and information, so we can have the capacity to collect the information that is most relevant. Next. Next, please. The objectives of this research is to evaluate the feasibility and efficacy of this tool to identify on how we can do microelimination in these communities of hemodialysis in this region and evaluate the safety, treatment, and the effectivity that we are doing. As secondary objective, the security, the adverse events, the frequency, discontinuation, and try to evaluate the barriers into the care and treatment in regional countries. Next, please. Inclusion and exclusion criteria. Patients that have older than 18 years old that are in dialysis and have Hep C, in any genotype, any stage, that they don't have a contraindication for the treatment or have a decompensated cirrhosis that will not allow them to visualize an impact of this treatment or the presence of carcinoma. We think that we're trying to enroll more than 300 patients in 50 MOHD places in different countries. Next, please. Identify the barriers. I already expressed this. We can continue. Define the response of the 12 weeks of treatment. Next, please. Next. This is one of the topics that is very important for those that are in AHO or WHO or in the ministries. If we can collaborate identifying the barriers, we would be doing a great support to the system, not only for the patients, but when we plan the next strategies and we can work in those barriers in the sub-regions or in the countries or in the subsystems within the countries. Next. Accountability. This is something that I wanted to insist on this on Ale during the last 2 years, showing basically that a scientific society has to be committed not only with the academic side, but with the democratization of knowledge, of access to the care of the health. And we need to get involved with civil society and with different institutions to define what is the best strategy to take care of our patients. In this case, specifically for those patients with renal failure and hepatitis B and C. And Ale has demonstrated with all the other projects that we have done, this network work has allowed us to optimize access, knowledge, democratize education, and thus democratize the care of the patient. And with this, I finish. Thank you very much.
Great. Thank you so much, Dr. Sola. It's great to see this microelimination project. And to see what work you've done. But next, I'd like to introduce Sophia Bartlett and Jennifer Van Gennep from Canada, who are going to talk about Canada's progress towards viral hepatitis elimination 2021 report, holding governments accountable. And I saw this report when it came out, and I thought this was a great goal for civil society.
Hello, and thank
to
you
be
to the
able to
organizers for allowing
provide
me
like
to
a
present
report
today.
card.
My name is Jennifer Van Gennep, and I am the
I think you
Executive
both are here
Director
for
of
the
Action
Q&A.
Hepatitis Canada.
All right, go
We
ahead.
are a coalition of over 70 member organizations from across Canada, and we're working together to hold our government accountable to their commitment to eliminate viral hepatitis as a public health threat by 2030. We come to this work with a social justice and health equity lens, and it's a privilege to work with this group. Today, we want to share about our progress report that was released about a year ago. I'd like to start with a land acknowledgement. In the spirit of truth and reconciliation, I recognize that I live and work as a settler on traditional lands stewarded by the Anishinaabe people, which include the Odawa, the Ojibwe, and the Potawatomi nations, collectively known as the Three Fires Confederacy. So why did we want to do a progress report in the first place? As I mentioned, our mandate at Action Hepatitis Canada is one of community accountability. Canada is a federation, so our federal government, the Canadian government, signed on to these international commitments to eliminate viral hepatitis, but is actually the provinces and territories. We're made up of 10 provinces and 3 territories. And that is the level of government where healthcare is delivered. So there's a bit of a disconnect when it comes to accountability. So the role of civil society in that accountability is very high. And of course, there's also evidence that supports the idea that non-governmental monitoring of local governments can increase compliance with these kinds of centralized mandates. So we decided to take this on. We also wanted to offer targets. There is no documentation that I have seen in Canada related to viral hepatitis that the governments have taken on that includes any hard numbers, any targets, any indicators, anything like that. So we wanted to provide some suggested targets for the provinces as well to measure their progress. In developing our metrics that we wanted to measure, we were very fortunate to be able to lean on the Blueprint to Inform Hepatitis C Elimination Efforts in Canada. This came out in 2019, and it is the result of significant efforts by the Canadian Network on Hepatitis C, specifically led by Dr. Jordan Feld. And we are very fortunate to have this in Canada to inform our policy advocacy. It is a menu of things that a wide range of stakeholders agree would be a good idea to inform elimination efforts. We chose 6 metrics. And we acknowledge that if we had chosen different metrics, the outcomes of our report may have been different. But we were looking for a balance between being very comprehensive and being very accessible. So we chose these 6. The first being planning. Is there an elimination plan or strategy in place? I think that's fairly self-explanatory. For testing for Hep C, we wanted to know if the provinces or territories had RNA reflex testing implemented. So this, of course, is if there's an antibody test that's positive, whether it is automatically tested for RNA without having to go back to the patient for another sample. If it's just done automatically at the lab. For testing to treatment link, this is where we lose a lot of people in Canada in our care cascade. So we wanted to know if someone could come in, they could request a test, be diagnosed, and start a prescription on the same day. And if not, what the barriers were to that being a possibility. For treatment, we wanted to know how many people were starting treatment every year in each province so that we could measure that against an annual treatment target that we developed for each province, which basically is based on 80% of the prevalence for that province and divided by the number of years between 2016 and 2030 to reach elimination. For Hep C prevention, this was a metric that we pulled from the blueprint. We were interested in the coverage of needles and syringes distributed per person who injects drugs. And then for Hep B prevention, we wanted to know if the province and territories were following the recommendation of the World Health Organization to give the first dose of a Hep B vaccine at birth. Some of our provinces and territories do, and some wait until 10 or 11 or even 12 years of age. This is not standardized across the country, so we wanted to capture that in our progress report as well. Here's an overview. As you can see, 7 of our 10 provinces are green on this map, meaning that they are on track. 3 are red, meaning they are not on track. And then our 3 territories in the north are yellow because we did not have enough data to determine whether they were on track or not. Probably for this audience, the makeup of the report is maybe more interesting than the nitty-gritty of each province and territory. So I'll focus here. There was a nice background section at the beginning to just sort of set the stage. Then that overview slide that I just showed you is one of the first pages as well. Then we had a report for each province and territory, like the larger one here on this slide, that showed the current status, whether the province was on track or not, a little bit of province-specific overview. Then we had down the left side the 6 metrics where they got either a green or a yellow or a red dot, depending on how they were doing. And then an estimated burden of Hep C in the yellow box, and the blue box is an annual treatment target. And then some recommended next steps. We also had a page outlining the federal government's role and our recommendations for them. We put this information about our priority populations right up front. We really wanted to highlight the need for a health equity approach to elimination in Canada. Correction settings in Canada are very different, a very different standard of care, unfortunately, from what is usually found in community. And so we highlighted the current state, the current human rights violations for the most part in our correction settings, and then some recommended next steps, both for provincial and federal facilities. We had a page about the bright spots, things that are going well in provinces that could be replicated in others. We have a big thick section of monitoring and evaluation methodology and our references. When we stack the provinces and territories side by side in this way, we were able to see some trends that were not really noticeable otherwise. And so one of the ones that stood out the most was the correlation between RNA reflex testing being implemented and that province being on track for elimination. It was almost 1-to-1. Where it was implemented, they were on track. Where it was not implemented, they were not on track. And so it looks like that could be a very key indicator. And we might not have noticed that otherwise without taking on this project. Another thing that stood out to me was treatment starts. As this slide shows for each province and territory, the trajectory of treatment uptake varies widely from province to province. We did not have the data for the territories, but of the 10 provinces, it varies widely. And you would think that if it was just about having DAAs available in the country, in the market, that the shapes of them, there would be more people maybe being prescribed treatments in some provinces than others based on population. But you would think that the lines would follow the same shape, but they very clearly don't. And I think this highlights for us the role and the impact of policy on treatment uptakes. When you can see in these charts, you can see when fibrosis restrictions were lifted in each province. And then beyond that, you can see that some continued to go up after the fibrosis restrictions were lifted. Some peaked that year, which suggests, maybe some warehousing of people that were waiting for that to happen. And then We were testing maybe not enough or not diagnosing enough people and starting enough people on treatment after that to maintain that trajectory. And then you will also notice that in 2020, every province went down. We had basically a pause in Hep C testing and treatment as resources were diverted for COVID. It'll be interesting to see when we do this again in 2023. We do this, the plan is to do this every other year. It'll be interesting to see which provinces were able to pull it back up to get back on track when we see the 21 and 22 data. It's important, I think, to acknowledge some data gaps that were in this report. Our prevalence data is not good. We're working with 2007 to 2008 modeling data at the province and territory levels. So they're not going to be accurate. They're almost certainly an underrepresentation. And this is a problem, of course, when our elimination targets are based on a percentage reduction from a baseline, and we don't know what that baseline is. That's obviously a problem. So how will we know if we have eliminated viral hepatitis in 2030 if we don't have good data? The other piece, of course, was prescribing counts. We had to license this information. It's not publicly available, and it's modeled as well. And although it's not bad, but it is an over and underestimate in some provinces. And there was no data available for the territories. So this is, of course, a problem. However, still, even with these limitations, the report had very good uptake among our allies, and it was well received by policymakers as well. They found it was clear what we wanted them to do. And so we've been able to have very good meetings, I think, with several of the provinces over the last year and with our federal government. And it helps them see and pick, gives them ideas of policies, places that they can make improvements. If they truly are looking to improve to stay on track or to get on track with eliminating viral hepatitis, then it is clear what it is that we want them to do. So like any giant project, there are lots of people to acknowledge and thank, especially listed here. Specifically, I want to thank Sophia Bartlett, Dr. Sophia Bartlett, my co-author, and our editor, Janitor Butler McPhee. This report is downloadable at actionhepatitiscanada.ca/progress report. Thanks so much.
Great, thank you, Jennifer. That's fantastic work, and I think this is something that other civil society organizations should think about doing for their countries as well. I'm going to pass it to Sergio for the Q&A. Go ahead.
Thank you, Sue. Gracias, Sue. Bueno, quisiera tomarme.
Thank you, Sue. I'm going to take a minute for those who do not know me. I am an organization in development. We have been working for 15 years, and we have the responsibility to generate therapeutic alternatives for underserved populations. And it was hepatitis C that incorporated this concept in our organization. And we have a commitment, and I work with some or many of you to expand our collaboration network. We developed 2 pillars, one of policy advocacy and access for the concept of starting treat. And in second pillar is the development of new therapeutical low-cost alternatives. With this said, because I can feel connected with many of the actions presented here, so I please feel free to ask questions in the chat. And I also am going to take the liberty to, since I do not, I will take the liberty to ask Victoria. She mentioned, Victoria, of certain recommendations that human rights institutions issued to the Ministry of Health. It would be very interesting to listen that if some of these recommendations were followed. Yes, this is one of the inconveniences that I have in our country. Like you have observed, many of the activities have been triggered or driven by the civil society. And right now, we have elevated them to the parliament, and they're right now in the Human Rights Commission in the parliament that they're reviewing the topic of viral hepatitis. So these 8 recommendations have to do with drafting a national approach plan for hepatitis A, B, and C, and to implement information campaigns like it has been mentioned repeatedly. Knowledge is power, especially for patients. We are concerned of these 3,500 patients that are identified, but we know that do not know their diagnosis, and they don't know that they have an affordable treatment is available. And so when we have this information gaps to be able to incorporate diagnostic studies, which is in civil society has had to drive, because sometimes we need to pay for a fee for transportation, and to strengthen the entities in the civil society. This is something that we have talked about many times. This is fundamental, that the link between patients, sanitary authorities, civil society, everyone that is participating should be interlinked. Well, thank you for your answers, Victoria. Patricia, you have a question. Thank you. I have a question for Victoria. And I have several questions, but Victoria mentioned that human rights entity of its country issued recommendations to the Ministry of Health. Could you talk a little bit more about these recommendations? Well, basically what Sergio just asked, but maybe I can expand on this response. We consider the lack that today in Uruguay we could do that work of the civil society. The government and our state has saved millions of dollars that for us, this is a complaint that these funds that were saved by the government can be turned to help the patients, for patients that do not have access to treatment. Thank you. I would like to ask Jennifer his presentation of a decentralization strategy, which is greatly important in terms of getting closer to where patients reside. My question is, which were the main challenges or difficulties that you faced in this process to be able to achieve the level of decentralization that you have proposed?
Thank you for the question. And Sophia might have something to add. To be clear, I'm not proposing decentralization. This is just the way our government works. If I'm understanding your question correctly, our government just does healthcare at the provincial and territorial level, but it was the federal government that made the elimination commitment. So So it's really around, our job is really how to hold them accountable. We're not really proposing a different way of doing healthcare. Sophia, do you want to add anything?
No, nothing more to add. Just I think to highlight the challenge with a decentralized model is then you have a lot more difficulty in collecting data.
Yeah.
You have 13 places that you need to collect data from rather than one place. So it's a double-edged sword and should be approached with caution. There are pros and cons. And I think just to highlight that what this report has been able to do is provide a wedge or a bargaining tool for civil society to actually get in the door to have conversations with government. It's very difficult for civil society to actually get buy-in to have conversations with government without having something that they can really take to be able to show tangibly, what the current situation is and what would be needed to get to what they're asking for. So I think for any countries or jurisdictions that are, wondering how they can have conversations with government about hepatitis elimination, they should really be thinking about, how can they gather data, what data is available, how could they translate some of these metrics into the relevant kind of context for their communities so that they can then have that kind of bargaining tool or wedge to be able to get into the door. Because what we've seen since this report came out was that it really opened up conversations between civil society and government. And without the report, those conversations had just been kind of stagnant. And now there's a lot of activity happening across Canada. And I think, we just hear such great feedback from all of the organizations that are part of the coalition, and also a lot of demand to produce updated versions of the report.
Muchísimas gracias. Quisiera preguntarle a
I would want to ask Marcelo, it was clearly that in the COVID-19 epidemic interrupted time treatment, but my question and for the example of Argentina is the strengthening of the health systems, of the diagnostic system, of technology. Do you wish? So how can you reverse the access to hepatitis work after COVID? Marcelo? Now I can you hear me? So the answer is yes. All technological development that facilitates outreach is going to help diagnosis related or continuation of care, so we don't lose patients, adherence and follow-up, and what has to do with therapeutic technologies that are accessible. That's where they can be important. Maybe the limitation that I don't fully understand is how can we make a health system that is so complex as the Argentinian, which is fragmented, that the policies or the interventions that are actually implemented and that they reach the patients. And we do not have good coalitions in this regard. And we have to, all stakeholders, civil society, paranational entities, ministries, the academia branch, the strategies that we have are not common. And I think that technological leap, if we cannot have common strategies, it would be another missed opportunity. And this is what's going on in Argentina today. We have access to antiviral drugs. The ministry has them, but they don't have the patients because they did not link the work with the patients. So it is a paradox. We have drugs, we have treatment, it is accessible. The private subsector poses barriers, the state doesn't, but we don't have patients that are identified. So I think we have to pay attention to this. Yeah, excellent response, Marcelo. Lastly, Eugenia, what are difficulties in the civil society work with the interactions with the authorities that are responsible for the programs? And maybe based on Marcelo's comment, can you highlight something that provokes us or that helps us identify barriers? Well, thank you, Sergio. Basically, fundamentally, what we see as barriers is a lack of information throughout the sectors in society, from the community, the general community, to the professionals and health workers, the civil societies linked to health, or linked to other pathologies, but are indirectly linked to a hepatic disease, like a hepatitis C, as an example. So these barriers are of communication and access. In my country, it is not common that a primary physician orders a test for hepatitis B or C in a routine medical checkup. A person that's more than 40 or 50 years, it might be requested, but someone that is going to have a surgery, these tests are not requested. So there is a gap there. And like Marcela says, then we do have treatment in the public system. We have access, and in the other social security subsystems and in the private insurances, we have them, but we don't have enough patients identified, or those that are identified, they get lost in this bureaucracy to access. Our country has this national program for several years. It has many strategies, and we have listened to them across this meeting, and the Ministry of Health presented it yesterday. And we have heard of the advances, and we have heard civil society's achievements, that civil society is watching that things happen, or that, but we have to know more, like the strategies in dialysis, but in the campaigns. But we need more interactions, and that's why we are working in this law, in this collaborative law, so that it goes across the different governments. And in our region, our governments change drastically from a way they think to another way they think, and that health strategies are not sustainable. That's why we had to go all the way to the parliament. Thank you. I think I have to wrap this session. Thank you for all your presentations. It has been a tremendous experience in our America region, and this can be shared and transmitted and shared to other countries, for example, the Caribbean, where Leandro is calling us to pay attention to this region. So these experiences could be shared with this Caribbean region. So it is very clear that the experiences that you presented here in terms of a clear and active voice, the legislative advocacy, highlighting strategies like microelimination to achieve high impact of the intervention, the decentralization of the programs to transfer responsibilities to the local levels. They're all excellent interventions that are key in our work and in our progress and get closer to where the patients are. It is clear the role of the civil society and the scientific community working with the primary responsibles, which are the health systems, and with the legal frameworks. The rights are essential to the progress towards the elimination of hepatitis, viral hepatitis. We have work to do, but we have great work in the region. And thank you for the organizers for this session.
I think Patricia wants to take a picture of the presenters, maybe. So, but we can let everybody else go off the platform and then take a picture of the presenters.
Good. Okay, thank you. All the presenters.
Are you taking it, Patricia?
Okay. Please turn on your camera, please. Okay. Sonríe. Gracias. Gracias. Les enviaré la foto.
I'll be circulating this photo.
Thank you.
Okay, thank you. I will circulate the photo.